introduce you to amazing people like you who are doing great things in the world that I think you should know about. Well, today is the first Monday of the month, which means it's time for Monday with the McDougalls. And today, Dr. John McDougall is going to be giving a review of the science. I wore a very special t-shirt in his honor and some very special earrings, but he has beat me because he wins the award for best shirt ever worn on Chef AJ Live. It was painted by a Palm Springs artist named Julie Smith. Please welcome Dr. McDougall. Hello, Dr. McDougall. How are you?
Hey, in honor of you, AJ, I put this short sleeve shirt on. It's not real warm outside today, but you know, I wear it with pride.
It is a work. It really is.
How excited I am when summer comes around and I get a chance to wear this shirt that you gave me. Has it been 2 years that I've had this, or just one?
I think so. And yeah, because it has to be 2 years because I left the desert 2 years ago. So I got it for you before we left.
Well, I'll tell you, it certainly takes the attention away from my face and puts it on my shirt where it belongs. How about that?
Well, I think it's a work of art, and you're a work of art, Dr. McDougall. Yeah. Here, people are saying, Dr. McDougall, the man that changed my life. So yeah, you've helped a lot of people.
I'm proud of that, AJ. I have to say that, when I started out, I thought that the ideas were so revolutionary and so powerful that my thoughts on what I discovered would change the world. Here it is, 48 years later, and the world has not come along. And so, I've decided a long time ago that since I couldn't get, any enjoyment or satisfaction about these worldly efforts, that instead what I do is I get my joy out of individual people, patients. And so it makes me feel really good to hear that I've helped you. I can't tell you. It's the greatest gift to be anybody who helps other people, much less a doctor who helps other people.
Yeah.
Anyway, I'm Dr. John McDougall. I'm a board certified internist. I'm probably licensed in many states in the United States to practice medicine. And I still have associate assistant. I don't know. I teach medical students, which brings me to a plea. If you know any medical students or residents that want to learn about diet therapy, we will take them under our wing for 12 days. Next one is in July, I believe, and we'll share with you. You'll never be the same. You'll look at everything different once you go through and you see people really get well, as opposed to getting drugged and staying sick and overweight. That's all you see. I mean, it must be horribly frustrating. It was for me when I was in the general practice of medicine more than 40 years ago, to see my efforts not rewarded with obvious benefits in my patients. They were no thinner, no healthier. They've just taken a whole bunch of pills. And it was very unsatisfying. And I'm sure glad I didn't have to live my professional career, only getting that kind of reward. Here, take another pill. This one doesn't work, come on back, I'll give you another pill. That doesn't work, I'll send you to a specialist. If that specialist doesn't help you, we'll send you to another specialist. And then we'll send you to the psychiatrist. The psychiatrist will blame you for your problems. You see, because we won't take credit for the failures. Anyway, that's kind of the way to practice. So anyway, I thought what I would do today, and I'll probably, I changed the theme of our getting together the first Monday of every month, which we've had the opportunity to do for a long time. And I hope you'll continue to have me as a guest. I've made some plans to review different things because, to tell you the truth, there's not that much new. The truth don't change, folks. That's why I keep telling you the same story, is the truth don't change. So what I have to do is I have to go back and kind of review what I've written 40, 50, well, not 50 years ago, probably 45 years ago. I have to look what I wrote and see whether or not it needs some changes. Maybe it needs some updating. Maybe I just should cross that sentence out and put something new in because it's all changed. Well, you know what? The truth don't change. And that's what this review will be for you, is to help you understand the things I've been trying to help you with for the last 47 years, or at least 40, are still relevant today. And to tell you the truth, the profession appears to be just catching up. was something that I had discovered. Wasn't hard, just looked at the papers, looked at the research. I had discovered more than 40 years ago. And, because of money, basically, these ideas have never become popular, and I don't ever plan on them becoming popular because it's all money driven, just like in your business. So anyway, I put these things together based on the science done, say, prior to 1985. Some of the stuff it was as late as 2011 that I had research available. But when people read my books, AJ, they'll say things like, why does Dr. McDougall use such old research? Well, excuse me, but the new research wasn't published when I wrote the books. All I had was the old research available. And you know what? The basics were discovered during my professional career and the 50 years before. Basically, everything was discovered. There are so few new opportunities for doctors and patients out there, since, the last 50 years for sure. And what has developed happened during my professional career. In other words, I saw the mammogram studies being published. I read them. I looked at the critiques. Same thing with heart surgery. I read the studies. I looked at the critiques and thought about it for quite a while. Then came to some conclusions, which fortunately I haven't had to change. But I will. I promise you I will. I hope AJ holds me to this. If she ever catches me telling an untruth or an alternative fact, that's what they call it these days. They call it alternative. Well, anyway, I hope you point out to me that I should correct my evil ways. But what I wanted to do today is I just want to kind of review the cancer business with you a little bit again. I know it's a tough subject. It's the thing that you most fear is being told you have cancer, isn't it?
Yeah.
Everything else you seem to think, well, they're going to help me or I'll get over it. But the big C, it's like a death sentence, but it's not true. And armed with information, not only can you avoid such tragedies, but if they do befall you, you can get humane care. Proper care based on science that does you more good than harm. And of course, that's the criterion I always use when I deal with you and other patients is, have I given you advice that does you more good than harm? Because, basically everything has a positive and negative effect to it. We just hope at the end of the game, you'll look back and you'll say, what you told me 6 months ago or 6 years ago really worked out well. But, that's based on history. Fortunately, with I've probably seen 15,000 people in my career so far. But over my career, I've had very, very few instances where I've had to tell the patient that, I could have given them better advice. And hopefully, like I say, I came forward and admitted that I had better advice to give you. I learned some new things. But I want to talk to you about the cancer issue today. And I know it's going to get a little bit deep, but I have to bring you through all this so you can understand what's going on. And you'll be able to understand the concepts of cancer much better than your local doctor does, unless your doctor's familiar with the research that I'm sharing with you. And once you understand the things that I'm going to share with you, it's yours. You have the knowledge. Nobody can tell you different if it makes sense to you. So anyway, that's what I'd like to do is see if I can help you in terms. I'm going to go do other things too. As time goes on, we'll go to obesity and diabetes and all kinds of other stuff. Okay, AJ, do you have me up and well? Am I looking good?
McDougall's medicine.
Yeah, what does it say there? McDougall's medicine
advances in the humane treatment of cancer.
Yeah. Yeah. And as you know, we're on every Sunday night, 5 o'clock, Mary, Heather, and I. And then I have the opportunity to better refine and put together the lectures I give on Sunday night to get them ready for the audience right now. And I put a bit of work in since last night. I put a few hours in to make it a better, more understandable presentation. And it takes a few times for me to give a lecture before I have it to the point where I don't feel like I have to make any major changes. But anyway, let's talk about cancer. My plea to you to avoid lies, alternative facts, or whatever you want to call them, is to look at the science. I'm a scientist. Science, if it's done properly, or even if it's not, I mean, you should be able to figure out its value. And so I encourage you to go to the basic research, at least for your problems or anything that as you have any curiosity for. And so one of the things about the presentations I give is that I always put an extensive bibliography of scientific references down in the right-hand corner of the slides. And you can easily look up the original article. Not only can you find it at the National Library of Medicine, which I've given you the address up there, the National Library of Medicine, half the articles are available as open access. In other words, the publisher gives you free access to the article. So you can read the whole thing. But half the articles, they'll charge you like $35 to $50 an article. I can't afford that. And so I have a way around it. I want to share that with you, and I feel good about it. Even though the publishers of various journals probably don't feel good about it because you're having access to something they feel that they have the sole right to, and they don't. I don't think so. I mean, the research that we're talking about was paid for by you buying their products. You're a consumer. You paid for that research. And also your tax dollars went to pay for a lot of the research. So it's really yours. And if you go to this website, Sci-Hub, well, that's pretty easy, isn't it? Sci-Hub.org. And you look up the articles that you want to read. You look it up at this website. Basically, all the articles published in the last 100 years, except for the last year or two, are there. I find research papers that are done 75, 50 years ago on this website. And what you do is you go to the National Library of Medicine. They have something called DOI, a digital object identifier. This is the key. It's a kind of a long number. You copy and paste it, and you go to Sci-Hub and you insert the DOI, and then you just push the enter key and the article appears. Now, to get it in the form you want at the PDF file, you have to save it. And of course, then you can read it as a PDF file. Anyway, it's all yours. I can only go part way with you. You have to take the extra effort to find out what the truth is. And once you are confident that you have the right message, then you can move on and get the kind of care you deserve. So please take advantage of this. Please hold me to the standard that I just explained to you. And that is if I'm not right, tell me and I'll fix it. Okay, this is the hard part, and I've been through this with you many times before, and I have to go through it with you again. This is something that very few of your physicians, even your oncologists, understand and certainly don't practice via this information. So this is unique, your understanding. And once you understand what I'm going to share with you now, which is the natural history of the development of cancer, then everything makes sense. But you've got to have this one basic concept to understand about early detection, treatment, etc. And then, of course, things make a lot of sense to you. All right. Let's see. We'll get some of these articles here a little later on. Kind of messed up a little bit. But let's talk about it. What happens is here's a cancer cell over on the left-hand side. You see that one cell? Okay. That cell is lurking in a mass called a breast or a prostate gland that contains 100 billion cells for one breast. That means 200 billion cells for two breasts. That means 100 billion cells for a prostate gland. So here you have this tiny little cell amongst 100 billion other cells. Do you think you could find it? No, I don't think so. So these cells, they have certain qualities that define them as being cancerous. One thing is they have to divide at their own free will. And the other thing to be really cancer is they have to have the ability to spread beyond the tumor. It's called metastases. So you have to meet those two criteria for you to really decide it's a cancer. So here we have the first cell beginning as a cancer cell. And what that cell does is something that really defines what's going to go on in the future. And that is this cell, because it's been damaged, has lost its growth rules. You know, cells are not allowed to double and grow anytime they want. Otherwise, you'd be a misshapen lump in a matter of hours. Your cells are allowed to divide if you're growing, or if, say, you injure yourself, the cells can divide to prepare the wound, but otherwise you're not allowed to divide. All right, so one cell divides into two. That takes on average 3.5 months, 100 days for a solid tumor. So after 3.5 months, you've got 2 cells. And then you wait another 100 days and you've got 4 cells. Okay? And then a year, you've got 8 to 12 cells lurking in a breast that contains 100 billion cells, or a prostate that contains 100 billion cells. Not detectable. But at these early stages, if it's really cancer, which is the second criterion, if it's really cancer, the second thing it has to do is have the ability to break out of the original tumor, go into the bloodstream. It goes into the venous bloodstream. It goes into the lymph nodes too, or the lymph system, but that's not important as far as metastases are concerned. It goes into the veins and it spreads to the liver, lungs, brain, bones, etc. And that, of course, is the cancer that kills. But nobody dies of breast cancer. Nobody dies of prostate cancer or colon cancer. You die of the cancer that's spread to other parts of your body that replace the lung tissue or the brain tissue or the bone tissue. And that's how cancer kills, is by replacement with these abnormal cells. Okay, so here we are. Let's go back to divisions. You're at 1 year, you've got maybe 8, 12 cells in your tumor. You get out here to a couple of years, you've got like 100 cells lurking in a tumor that contains 100 billion cells. You can't find it. And yeah, you've had cancer for 2 years. And really, at these early stages, it spreads, if it's going to spread. But I have to tell you, a lot of the tumors don't have this second quality. They look like cancer when you look at them under a microscope, but they don't spread to other parts of the body. And that's where a lot of people get fooled when they're told they had cancer, because they were fortunate not to have the kind that is going to spread. Anyway, back here to divisions, you're at 2 years, you've got 100 cells. And you continue to divide. And at this rate, after 6 years, you've got a tumor mass the size of a period of a pencil, the size of a lead tip of a pencil. It's just a dot on the page. That's all the bigger it is. And it contains 1 million cells, and it is a millimeter in size. Like that tiny. And by that stage, if it's really truly cancer, and it's really the kind that spreads, it's spread pretty much 90+% of the time. But you still can't find it. You could unleash a team of pathologists, and there's still, a dot that small lurking in a breast as big, a mass the size of a breast or a prostate. It would be a very difficult task for them to find it. Okay, let's go back to the divisions. It keeps dividing, and finally you've reached a tumor mass the size of an eraser of a pencil. It's a centimeter, about 1/2 inch in size, and then on average, it's detectable. It's been growing for 10 years. And by that time, again, if it's truly the kind of cancer that spreads, it's already spread. The cattle are already out of the barn before you close the door. All right, so I told you on average, it's 10 years. But some tumors are found earlier, like at 6 years. On average, a woman who checks her own breasts will find a tumor when it's, only been growing for 6 years, because the more rapid growing tumors, a woman is more likely to find herself. Okay, and then we got 6 years, the earliest by breast self-examination, but still, that's late disease. Excuse me. And then you go out here, 10 years is the average, but because mammograms detect slow-growing tumors. Primarily, they've been growing an average of 14 to 17 years. before you can find them. And when it comes to prostate cancer, before the PSA, the prostatic specific antigen, will rise in the bloodstream, so it is detected as a positive PSA, it's got to reach a size of a centimeter. It's got to reach the size of an eraser of a pencil before it raises the PSA level. So the point I'm trying to make here is early detection is really late detection. When it comes to treatment, you're dealing with a disease that's all over the body. If it's truly cancer, it's a systemic disease. Well, with that in mind, let's go into some of the subjects that are pertinent to you as far as your care goes. Let's talk about dietary cancers, hormone-related cancers. Let's see if we get back here. There we are. For dietary derived hormones lay the foundation for hormone-dependent cancers. Hormone-dependent cancers are breast, ovary, and uterus. Testicular cancer in men, but breast, ovary, uterus. And I believe, based on the science, that most of these cancers are initiated, in other words, started by environmental chemicals that have been produced through industry, manufacturing. There are environmental chemicals called xenoestrogens, which act just like powerful estrogens that are released, in huge amounts every day in our environment. So how do you protect yourself from these environmental chemicals? Well, you don't live downwind from a factory. And I say that thinking of a story of a patient who came to see me with breast cancer. Both her sisters had breast cancer. And then as we were talking about, she said, yeah, and we lived just downwind from this smokestack that covered our house daily almost with, plumes from the factory of chemicals. And all three of them had breast cancer. Anyway, the initiation and the promotion, once it starts, and the promotion, the acceleration of growth, I believe is caused by environmental chemicals. So you don't want to live in any industrial areas if you can avoid it. The second thing, wherever you live, it doesn't matter, you can eat low on the food chain. If you look at the picture I have here in the bottom left-hand corner, it tells the story. And what it talks about is bioaccumulation. In other words, the body bioaccumulates chemicals. And it's called biomagnification. In other words, the body magnifies the power of these chemicals. All right. So you start out with low levels of chemicals on the grasses and grains and seaweeds and algae and so on. And then the fish will eat these plants. And then bigger fish will eat the little fish, and bigger fish will eat those fish. And, you finally end up with the person eating the fish, and they're way up the food chain. Or let's just take the cow. The cow grazes on grass and grains that have low levels of environmental pollutants. Because they're fat soluble, they're attracted by body fat. They're accumulated in the cow's fat and biomagnified thousands of times fold because they're sucked up into the fat. And then we eat the cow fat and we concentrate it further. And then the end of the food chain is baby breastfeeding. And in fact, there was a study done by the Environmental Defense Fund back in 1979, looked at 1,400 women in 48 states, and it declared their breast milk to be a health hazard because of the chemicals in it. Today in Alaska, Inuit women who have a diet very high in fish and mammals, still, their breast milk is so contaminated with environmental chemicals due to the bioaccumulation that the recommendation is to bury leftover breast milk in a waste dump. Okay, enough of that. So that's how it starts. The other thing you need to understand is the implications of these chemicals and also estrogens. There was an article just came out a couple days ago. It was in the New York Times. It was titled, "Puberty Starts Earlier Than It Used to, and Nobody Knows Why." Well, somebody knows why. I know why. This is an article, "Menarche and Time to Psychoregularity Among Individuals Born Between 1950 and 2005. What they found is that compared to 1950, if you compare that to 2005, little girls are maturing 6 months earlier, or half a year earlier today, or in 2005, than they did in 2050. So over a period of 50 years, the onset of the menstrual period in a little girl has decreased by 6 months. All right. If you take a look at some of the material that I published in 1985, I know this sounds a little bit like I told you so, but I don't mean it that way. I just want to explain to you that this information has been around forever. It's survived the test of time. In the book, McDougall's Medicine of Challenging Second Opinion, in chapter 5 on precocious puberty, I talk about maturation, menarche, that has changed over many years. For example, in Britain, the average age of menarche, that's the bleed, the first time you bleed, was 16.5 years. It's gone down in 150 years to 12.8 years, the average onset of menses. So what is that? That's like 4 years earlier. In the United States, girls started their first period at 14 in 1900. By 1960, they were menstruating on an average of age 12.7. All right. In Japan, in 1875, girls became women at 16 and a half years old. In 1950, they started their first period at age 15.2. By 1960, the age of menarche was 13.9. And by 1970, it fell to 12.5. So this has happened all over the world through all of the time we've had to make the observations. We've seen the change in onset of maturity of little girls and little boys, by the way. Same thing happens in little boys. We've seen them change from an onset of maturity, which used to occur at the time when you planned on having a family. Menstrual periods, like in New Guinea, in Papua New Guinea, the average onset of the first period in little girls used to be 18 years of age. Well, when you get to be 16, 18 years of age, your role in life changes. You get into your reproductive years. That's the time to have sexual hormones and maturation of your reproductive organs, not when you're 8, 9, 10 years old. So there's an obvious plan here, is that you don't become a woman until you're supposed to. Well, the sad thing is in this day and age, we have data that says, for example, little black girls, a few, not many, the little black girls by age 3, age 3, have developed pubic hair and breast buds. And by age 9, at least half of the little black girls have developed breast buds and pubic hair, which is different than the first bleed, which is called menarche. So, the average, probably the average of a little white girl in the United States is around 11 years of age for the onset of her first bleed. A little black girl around 10, and it has to do not with race, it has to do with environment. It has to do with the kind of food that these segments of the population consume. And that is, unfortunately, our Black population is less fortunate in terms of having knowledge and opportunities and finances. And as a consequence, in general, they eat a worse diet, no worse than the average American. They have higher rates of prostate cancer, double the risk of breast cancer, higher levels of obesity than comparable races. And again, it has nothing to do with the color of your skin. It has everything to do with your opportunities in life. Anyway, this just came out a couple of days ago in the New York Times, but I've been writing about it for 47 years. The other thing I want you to know about is the effect of estrogen on these hormone-dependent cancers. The average woman consuming the Western diet has 50% greater levels of estrogen in her body than does a woman following the kind of diet that I recommend. 50% higher levels throughout life, which results in earlier onset of menstruation. Here I have it listed at age 12. It results in later menopause. So your time of menstruating, the years of menstruating have been increased by 3, 4, 5 years, which means greater stimulation to your hormone sensitive organs like your breast and your uterus. They're stimulated longer, and they're stimulated at higher levels by the estrogens. Where do the estrogens come from? They come from the kind of microbiome, bacteria grow in your bowel. Body fat makes estrogens. Yeah, your fat cells turn adrenal hormones into estrogens. Another interesting thing has to do with cow's milk. I think this is rather interesting, to say the least. Is, cows used to be family pets. You kept them in the backyard. You celebrated Bessie's birthday, and when she got pregnant, you gave her time off. And you took only a quart of milk from her every day. Well, today in the modern factory farming, the average milking is 24 quarts a day. And when the cow gets pregnant, she doesn't get any time off at all. And they continue to take milk from her during the entire pregnancy. Well, during pregnancy, you have exaggerated levels of estrogen. And the estrogen stimulates these. And so you want to make an effort to reduce the estrogens, primarily by a healthier diet. A healthier diet, well, we've seen some real benefits. Warren Chablowski, which, by the way, you will find an interview I did with Rowan Chablowski on the website. Just go to drmcdougall.com. Put in Chablowski. His name is spelled here up in the left-hand corner. You see it, Rowan Chablowski. I had him on my TV show and also on my radio show. And during the radio interview that you can listen to, I asked Rowan Chablowski why he was feeding a moderate diet to women during this test. The goal was to have 20% of their energy intake from fat. Actually, it turned out they consumed about 35% of their energy as fat. Well, I said to Rowan Chablowski, I said, look, you're doing this one study for tens of millions of dollars. You'll never have another opportunity again. Why don't you feed them the best diet that you could possibly design, which happens to be the McDougall diet, by no coincidence, which is only about 7% fat. If you're going to show any benefits, why not give them the full dose of medicine as opposed to a partial dose? Anyway, after many years, after 20 years, you find that those on the low-fat diet survive longer. And that's studies that were recently published in 2020. So, if you are a woman and you're at risk of breast cancer, which you are, you have about a 1 in 7 chance of getting breast cancer. Then if you change your diet, hopefully before you get the cancer, but even afterwards, you're going to live longer. And this is just one study, the largest study ever done on the dietary treatment of breast cancer by Rowan Chablowski. All right, the diet that's 7% fat, the one that I've been preaching to you for a long time, is a diet based around starches like rice, corn, potatoes, beans, peas, lentils, breads, pastas, etc., with the addition of fruits and vegetables, green and yellow vegetables, a few fruits. How much? How much of the diet should be starch? Well, I say 90%. Yeah, you look at your plate, and almost all the food on your plate should be a starch. Oh, a little fruit, little vegetable, that'd be fine. Now, Mary, my partner in life, she says, no, you look on the plate, you'll see 70% starch. Well, maybe. Somewhere between, just the bulk of the food on your plate needs to be starch because you need the energy. They're perfectly balanced for your needs. Protein, vitamins, minerals, fibers, etc. Starches are. Fruits and vegetables, they add some color, flavor, texture, aroma, and a few vitamins like vitamin A and vitamin C, which can be deficient in some starches. All right, let's talk about progress that's been made recently in the humane treatment of breast cancer. This is during my career. This is what I see happening now. It should have happened a long time ago, but it's happening now. There's a procedure if you get breast cancer called a lumpectomy, where they just take the lump, relatively non-deforming. Now, of course, I request that they take the lump with clear margins. That means you don't see any tumor cells escaping out of the margins of your surgical specimen. Lumpectomy plus clear margins. You get great local control, and most importantly, you get the same survival benefit as you would if you amputated a woman's breast, which is the other option, which is still commonly done. Like I think the last data I saw was 63% of women get mastectomies, as opposed to more humane treatment like a lumpectomy. All right. Anyway, you lose your breast. They used to take the muscles on the affected side. In fact, at the turn of this century, between the 1800s and 1900s, there are some surgical businesses that would not only take the breast and the underlying muscles in the chest wall, they take the lymph nodes in the armpit, and they take the arm on the affected side. And then early 1900s, Halsted came out with a modified, or the Halsted mastectomy, which became the norm up until I was in practice. And that's where you take the breast and the underlying muscles and the lymph nodes. And then we had the modified radical mastectomy that left the muscles. We just took the breast and still dissected the lymph nodes, took the lymph nodes out of the armpit. And then eventually we got to the point where instead of taking the entire all the lymph nodes under the arm, the entire mass out, which is what they were doing, they just took one node called a sentinel node. All right. And so the current practice of medicine is you do a surgery on the breast, a lumpectomy or a mastectomy, and you take out one lymph node. That's it. It's called a sentinel node. And you base your treatments and everything else based upon taking out this one lymph node, which is still an added surgery. You know, when you have the axillary node dissections done to the full extent, you end up with serious disabilities, like a swollen arm and a painful arm. Anyway, obviously, if you get the same results, you want to take the treatment that will give you the best cosmetic as well as health benefits. This should have been all settled in 1970. Bernard Fisher, who in my lifetime was one of the most important people in the cancer business, known worldwide, Bernard Fisher. And he did the first randomized controlled trial on the treatment of breast cancer by various means. Now, I want to focus your attention on the left-hand part of this slide. And you see where it says, look? All right, I want you to look at this. This is the survival benefit. This was 1970. Okay, this is what, 54 years ago. What he showed was that over time, if you have a mastectomy, you live just as long as if you only had a lumpectomy. You live just as long as if you have a lumpectomy plus radiation. Now, I want you to notice the survival is the same for all three of these. And in particular, I want you to notice that adding radiation to the lumpectomy adds nothing beneficial. Okay? This study by Bernard Fisher was followed up for 25 years with multiple reports that showed the same thing. There was no significant difference in overall survival among the treatment groups. This is uncontested research, ladies and gentlemen. It should have been settled. But I can tell you, right up until months ago, I've had arguments with some of my colleagues, very close colleagues, ones that I have a lot of respect for, about not doing radiation with a lumpectomy. And of course, they thought I was wrong until we looked at the science. And then when we looked at the science, we found out that it was, to say the least, inadequate. And they totally ignored Bernard Fisher's work, which is the most important work ever done on the treatment of breast cancer. Ignored it. And so pretty much every woman who got breast cancer over the last 50 years either had a mastectomy, a modified radical mastectomy, a lumpectomy plus radiation. Extremely unusual for you to be offered just a lumpectomy alone with no radiation. Now, the radiation is with consequences. You have to attend a radiotherapy business. You have to have radiation administered to your chest wall. If it happens to be on the left side that you're getting radiation, that's where the heart is. And you double your risk of dying of heart disease if they radiate the left side. You suppress the immune system with radiation, the entire immune system. All right, so 1970, this was all published, and this argument continues to today. And I can pretty much guarantee you, if you have a breast cancer discovered and you go to see the doctor, you're going to be offered a lumpectomy plus radiation. Plus radiation. You're going to be told it's silly, it's stupid, it's whatever. I don't know what adjectives they're going to use, but you're going to be belittled. I've seen it. If you suggest that you don't want to have the radiation. It shouldn't have happened since 1970, but it certainly shouldn't happen anymore. It shouldn't happen anymore because this study published in February of 2023 looked at whether or not there were benefits from adding radiation to a lumpectomy. Look up here in the pinkish area where I outlined it for you. No radiation, 5 and 10 years, 10% of people, their overall survival, how many were alive at 5 and 10 years? Look at the figures. Let's just look at the 10-year figures. No radiation, 80.8% of people were alive at 10 years. But if you got the radiation, it was 80.7%. It doesn't work. It didn't work then, didn't work even before Bernard Fisher published his study, and certainly doesn't work now, but I pretty much assure you that's all you're going to be offered. Maybe, if you do what I suggested at the beginning of this lecture, and you pick up the research paper like I showed you how to do, and you took that into your treating doctor's office, if your treating doctor didn't throw you out of the office and tell you to find somebody that will do things you want done, and which is quite often what happens. You know, if the doctor is reasonable, in other words, is acting like a doctor, interested in your welfare, he or she will sit down and read these papers. Start with Bernard Fisher, read all the intervening papers, because I've read them, which, again, show no benefit. You kind of goose the writing a little bit. You can fool a few people. And then you show them this study, published in the New England Journal of Medicine, the most respected journal in the world, at least one of them, the Big Five, in February 2023. No benefit by adding radiation, but you're going to get it. All right. And the reason that it doesn't help to add radiation is by the time the cancer is diagnosed, it's 10 years old. By radiating the breast, which is, a local radiation, you're just treating a local area, just like surgery treats a local area, does nothing for the disease that's spread throughout the body, the systemic disease. Nothing. Because you're treating just a local area. So the reason adding radiation doesn't help is because what determines the final outcome of the disease happened long before you discovered it, much less treated it. Fortunately, a lot of tumors, in fact, a very high percentage, you're told you have breast cancer, it'll never kill you. It never spreads. Or if it spreads, you die of something else first. It's called overdiagnosis. We've talked about that before. Your chances of being overdiagnosed, in other words, you're told you have cancer, but you really don't have anything that will threaten your life, is extremely high. All right. So now you know why. Okay. This is what I wrote in 1985. Here's the section out of the book on the left-hand side, talking about the axillary nodes. I don't know why the nodes are in yellow, but that's probably the research thing it did. Back in 1985, I said, don't take the lymph nodes out. I said, don't take the lymph nodes out because the lymph nodes are there to fight the disease. And if you take these disease-fighting lymph nodes, the immune system, if you take and destroy it by removing it, what you've done is you've compromised your immune system. April 4th, 2024, this article appeared in the New England Journal of Medicine. Omitting axillary dissection in breast cancer with sentinel node metastases. What it says here is it makes no difference. Even if you have a positive sentinel node, in other words, one of your nodes is positive, it doesn't make any difference whether you leave it alone or you end up doing a total removal of the lymph nodes. It makes no difference. And that's what this particular article tried to share with you. Don't take the lymph nodes out. Don't get added radiation routinely. All right, let's talk about screening. Screening, early detection fails to save lives. Again, this is new stuff I'm trying to share with you, things that I have written about 30, 40, 50 years ago, which should have been information available to you for the last 40 years, but it wasn't. All right. Well, the only way you can tell whether or not a screening method works is this. You take a large group of people, you divide them into two halves. One group is the intervention group, which is what you do something with, either give them a drug or a test. The other is the control group, which you don't do anything extra to. If a early detection methods works, you should see more people alive at the end of the study in the intervention group than in the control group, right? I mean, after all, look, what you're asking for early detection is you want to live longer. Well, what you ought to show at the end of the studies is that those who underwent the screening technique, there were a larger number of people alive than there were in the control group who didn't get the screening. Does that make sense to you? This is the criterion that you use to determine whether a screening technique works or not. And none of them work except for one. A 15-year follow-up on screening of men with a PSA test just came out. Just came out in May 2024. Couldn't be any more current, could it? You know, a large number of men, 15-year follow-up, no survival benefit. Okay? 15, you know, they've reported it year after year after year. The results have always been the same. No, why is there no survival benefit? You know this. Come on now. We've been talking about this all along during this lecture. You know this. It's because by the time of the PSA is positive, it's been growing for 10 years. If it's is the kind of cancer that's spread, it's already spread. Right? We're all on the same page here, aren't we? All right. So prostate cancer fails. And how about colonoscopy? Hard to believe, but they've been doing colonoscopies for at least 40 years. That is a procedure that came into popularity when I was a young practicing doctor. So, you know, there was a time when they didn't do colonoscopies. All we did was sigmoidoscopies. Anyway, in that period of 40 years, they have done no proper studies on testing the benefits of colonoscopy in terms of living longer. None. Until they did this one study. And I doubt if they'll ever do another one. This was a study involving 85,000 people from Western Europe. Okay, this is people from Poland, Norway, Sweden, and the Netherlands. In that part of the world, colonoscopy is not routinely recommended. So they had a rather native population. They'd not been treated or tested before. So they took this large group of people and they divided into two groups. One, the intervention group, they got the colonoscopies, and those who didn't get the routine colonoscopies. At the end of 10 years, the first and only randomized controlled trial showed no survival benefit. Okay, it's right there. You're not going to read this paper and come to any other conclusion, unless, of course, you happen to be making money from colonoscopies, because the backlash from this was huge. When this study came out, just last year, or 2022, when this study came out, there was a revolt among gastroenterologists who said that this can't be possibly true. We know otherwise. Well, a lot of reports came out and said, you know, finally the colonoscopy business has been exposed. The emperor has no clothes. Why? Why do you see no benefit from screening colonoscopy? Why? Come on, now, we talked about this. How old is the disease before you can find it? How many years has it been growing before you can find it? 10. And if it's truly a cancer that's going to spread and kill, what has happened? It's already spread by that time. Intervention will make no difference whether it's a test or a treatment in survival. I'm talking about local intervention. Now, you know, there's some systemic intervention, which would be diet therapy, and systemic intervention would be chemotherapy drugs or, you know, variations of such. But look at what the study shows. Died from any cause, invited group, 11.03%. From those who didn't get the colonoscopy, 11.04%. 10-year, first and only randomized controlled trial ever done. All right, this is a good review. I encourage you to look it up. It'd be well worth your trouble. This is an article published in JAMA Internal Medicine, 2023. Now, I'm showing you research that's been published in the last year or two. And you say to me, Dr. McDougall, why are your research references so old? Well, excuse me, I wrote the books a long time ago. That's all the references that were available. But look at what the current science shows. The truth don't change. Anyway, this is a review paper of all of the screening tests that are common these days. And what they read the conclusion, okay? Conclusion and relevance. Does not substantiate the claim that common cancer screening tests save lives by extending lifetime, except for possible colorectal screening by sigmoidoscopy. I have given you over the last, I don't know, 5 years or so, I've probably given you this lecture 10 times, sharing with you that probably sigmoidoscopy is a test you can get done where it does meet the criterion of you living longer. Why? Because a colonoscopy is a dangerous test fraught by complications such as bleeding, infection, anesthesia, perforation, all kinds of things. So you may save one person by detecting a colon cancer early, but you've killed another person in the process of doing it. All right? The exception would be sigmoid, which is where you find the tumors, but it's such a benign test. You know, it costs like $200-300. It's done in an office, no anesthesia, no complications. Just take this short little tube, look in there, and any polyps you find, any precancerous lesions you find, the ones that are really important are within the reach of the sigmoid. But will you be offered a sigmoid exam? No. If you go in and ask for one, will the doctor comply? No. I have had many people, since I've been talking about this, they go into their doctor, they say, doctor, I don't want to have a colonoscopy, I want a sigmoid. Well, go someplace else. We don't do it. You will not find a doctor in your community that will give you a test, the only test that's been shown to prolong life based on randomized controlled trials. They will not provide that for you, called a sigmoid. $200 it costs. What does a colonoscopy cost? $3,000. Not that there's any relation. All right. And you know why these early detection techniques don't work? Because it's late detection. It's 10 years old by the time these methods detect the cancer. Remember, a cancer has to be the size of an eraser of a pencil. It's got to be a centimeter in size before it can be detected. All right. Last thought I have for you, and we'll be ending this long lecture on the details of cancer that you thought you probably didn't need to know, but now you do. Now you know you need to know. because you need to defend yourself because nobody else will. All right. Over my lifetime in the practice of medicine, which has been over half a century, I started in 1968. Many patients come to me and said, Doc, I have this terrible disease. It's often cancer. And my other doctor has recommended that I participate in a clinical investigation of a new experimental drug. Should I do it? They would ask me. And I would tell them, no, don't do it. You're my patient. My job is to protect you, because these studies result in more harm than good. And here's the paper, May 20th, 2024. It says, many studies suggest a survival benefit for cancer participants. However, these benefits were not detected in studies usually using design addressing the important sources of bias and confounding. Full results of high-quality studies are not consistent with beneficial effects of trial participation. Let somebody else be a guinea pig. You don't need to be. Not as my patient, you don't need to be. All right. So to end this thought, if you want McDougall's medicine, a challenging second opinion, then you'll likely have to get it yourself. I've written a couple of books. I think right now, McDougall's medicine is free on our website. You can pick the book up for nothing. Just go to drmcdougall.com, go to the store, and put the McDougall's medicine, a challenging second opinion in your checkout box. And when it comes to the bill, it says zero. It's free. We give away a different book every month. I've got 7 books that I own. Still 6 of the books are owned by publishers, which is a big deal because, some of those books are 30 years old. How many books are on a best-selling list after 30 years? Not many. Anyway, 7 of them I own, and we'll be giving away at least 6 of the 7 books over the course of time. Usually every month we offer a new one. But you can get McDougall's medicine on the website now. You can also learn about our 12-day telemedicine support and education program. And I do want to emphasize the support part. Well, let's start with the telemedicine part. When you sign up for the program, as long as we're not running a program at that time, the day you sign up for the program, we're going to schedule your first visit with Dr. Lim, who's our medical director. He's trained with me for over 8 years. Very competent, also a really nice person. You'll like him a lot. Dr. Lim will meet with you, get you started. And then what will happen is a few weeks later, or maybe a few days later, we'll start the 12-day program, which is when we really get involved with you personally and professionally. At that time, Dr. Lim, of course, will review everything that's going on with you. And he'll also see you a couple more times during the program, at least. You'll be seen more if you need to be seen more. And during the program, you'll get a lot of support. You'll get, we have 2 support specialists, well, 3 at times. And what they'll do is they'll get up with you every morning. They'll check your blood pressure, your blood sugar, at least ask you what they are. It'll be over the internet. You'll be at home. How you doing? What are you going to cook for breakfast, lunch, and dinner? This support specialist, which is Stacy and Tiffany, they'll help you through the whole day, not just in the morning, but throughout the whole day if you need it. And this support not only goes on for the 12 days during the program, but it continues for a year. Not at that level of daily visits, but weekly and monthly visits. It continues for a year. If you haven't figured this out within a year, likely you're going to have to take a little break and come back and see us again. That's what I'd suggest. Second time around is often better than the first time. First time, the program is a little shocking to people, some of the people, and they have to kind of think about it for a while, and then they prepare themselves, and when they come back the second time, they're more ready to learn. And you know what they say, the third time is the charm. So some people do come back 3 times and more, but It's because that's where they get the support and the education they need. Plus, the education is extensive. Chef AJ, she lectures with us. Doug Lyle, Jeff Novick. We have a lot of really talented people. Heather lectures, and I'm sure I'm forgetting a few. Jack Dixon, our exercise person. We have a pretty full staff, to say the least. And we do follow-up tests with you. And what we find is with this new program that's run over the internet, all the cooking's done in your own kitchen. We have better compliance. We have better results. We get better weight losses, better drops in cholesterol than we got in our 2 residential programs. We ran the McDougall program at St. Helena Hospital for 16 years. And we ran it through a resort in Santa Rosa, California for 18 years. We've been doing this one for, it'll be 4 years this August. And we've got data. And the data shows that not only are the staff much happier, but the participants are. And we've had many people who have been to both programs. And as I recall, their comments were that they enjoyed the telemedicine program more and got much more out of it. And were better able to follow the program than they were by flying 1,000 miles out to Santa Rosa, California, staying with us in a hotel. Yeah, this is a better program. All right. Well, what do you think?
Well, it's certainly much more cost effective now, and people from all over the world can easily take it.
Yeah. Well, AJ, I've given you this material on cancer, like probably you've heard it 30 times. Is it starting to make sense to you, the natural history?
It never gets old, but people still have questions, including myself. And one of the questions I had, which a couple of the viewers also posted, at the very beginning of your talk, you said about how when it's 1 millimeter, it could have been there for 10 years.
Well, it's on average 6 years at a millimeter. 10 years is a centimeter. That's on average. Some may grow to a centimeter in 3 years. Some may wait 35 years. When you follow up women who have breast cancer, you'll see them dying of their original tumor 35 years after they were diagnosed. So you live a long time. This is a slow-growing disease, and you slow it even further by eating a healthy diet. I showed you Ron Chablowski's work, which should have been done with the McDougall diet, but wasn't. Probably never will be. Could be. Should be. Because that's the lowest fat intake and healthiest ingredient intake of any program you can put together is the starch-based diet that I developed, half a century ago. So what was the question, AJ?
Well, the question was, you had said you don't die of the primary tumor, you die of the Mets. So when do these Mets start happening? Are they diagnosed right when the person is first diagnosed with the tumor?
Oh, they've happened long before that. The spread, let's just say, you can't really say, because it could spread when it's only 4 cells, or 10, or 12, or 16, or 100. But as more time goes on, you're more likely to have effective spread taking place. You can actually, in fact, Ronald Reagan, the president, when he had colon cancer, they reported they took blood from his tumor. All right, so they got into the abdomen and they took a needle and they stuck it in the vein that was draining the tumor. And they found tumor cells in the blood. How often do you find them? I believe it's 100% of the time, but I'll have to look it up. I published it many years ago, this is when he was initially diagnosed, which was probably a 10, 15-year-old disease. So you can't really say that it doesn't spread when it's less than a year, because it probably does. Does it spread after 20 years? Well, sometimes it doesn't. Quite often it doesn't. In women, let me just tell you, in women older than the age of 70, if you have a mammogram done, you have 1/3 chance, 33% chance of being told you have breast cancer, and you don't. If you're over 80, they're called overdiagnosis or a false positive. If you're over 80, you have a 50% chance of being told you have breast cancer, and you don't have any tumor that would bother you. So I'll give you some other numbers. If you screen 2,000 women, somewhere between 10 and 50 will be told they have breast cancer, but they'll never die of it. And out of those 2,000 women, maybe one life will be saved. But out of those 2,000 women, somewhere between 200 and 600 had to go through further testing and treatment. See, that's the harm done. The harm done is being told you have cancer because your whole life changes. You can't get life insurance. You can't get health insurance. You can't get a job. Your friends, they don't say, Betty, how are you? They say, breast cancer. Oh, how you doing, Betty? Your whole life will change. With a false diagnosis, be careful what you ask for. And if there was any survival benefit, and I showed you there wasn't, didn't I just show you that? From early detection with mammograms, didn't I show you the research paper just published last year? JAMA Oncology, didn't I? Yeah, I did. You can look at it again. Anyway, you're left with harm and no good is the problem. Should you take a cancer out of the breast when you find it? Yeah. And why should you do it? Well, because if you don't, it was likely to grow bigger and through the skin and into the muscles and maybe the bones. And it becomes a very difficult mess to take care of. I've taken care of, or I've had at least 6 patients in my career who decided not to have any surgery of any kind or any treatment of any kind at all. And, you know, I've actually taken pictures of their breasts. I don't know whether I can still find them, but, you know, it's not a pretty thing, to say the least. That's why you remove it, is you want to have a good local control. You don't want to be bothered with a piece of hamburger on your chest for the rest of your life, which is what it looks like, a piece of raw hamburger.
But you only recommended for breast cancer, the removal of tumors?
No, I recommend, well, for prostate cancer, the general recommendation is to do nothing. That's what the medical business, you see, this is a male-dominated medical business taking care of men. So we're a little bit more reasonable in our recommendations. For the last 20 years, in fact, this study I just showed you, a 15-year follow-up. It was based upon the fact that more than 20 years ago, if a man got prostate cancer, definite diagnosis based on biopsy, he was told that he has several choices. He can have radiotherapy, he can have total prostate removed, or he can do nothing, which is called watchful waiting. And so groups of men got together, 20 years ago. That's why this study on 15-year follow-ups I just showed you is available. And a big bunch of them said, I'm not going to have any treatment at all. And the doctor said, good, you shouldn't. That's a reasonable option, is watchful waiting, they call it. It should be, I'm not going to have treatment because you'll harm me. That's what it should be called. But they call it watchful waiting. That, I guess that they calling it that makes it less scary. In other words, we're standing there waiting, and if it comes, we'll get it then. No, they weren't going to get it then. So, okay, so we do nothing with prostate. We take the lump out with a lumpectomy. Where else would you be dealing with it? How about the uterus? No, you just take the whole uterus. I mean, that's all that's ever been done. The ovaries, you just take the affected ovary. That's always been done. Colon, well, this gets down to another topic, and this is a research done by Dr. Madden, M-A-D-D-E-N, from New York. And it was published in 1980. It's in the cancer lecture that I've given here, AJ. I gave it a few months ago, and people will go to YouTube and look up Chef AJ and cancer and McDougall, and they'll find that lecture. Anyway, Madden, he took care of people. Well, he was a general surgeon, but he had patients that had a tumor which was present in the last part of the sigmoid and in the anus. Okay, they're very low down in the intestinal tract, just about the end of the intestinal tract. This is a very difficult area to treat because it's, you can imagine it's right at the margin between the outside and the inside. All right. So the way that this is treated is with something called an abdominal perineal resection. I've told you many times that I put myself through medical school working as a surgical nurse. I basically lived in an operating room for 5 years and, did, somewhere between 6 and 12 surgeries a day. I was the nurse. And we would have abdominal perineal resections. And I always knew what we were going to do because we had 2 tables set up. That was my job, setting instruments on the table and handing them to the doctors. Well, I'd have two teams that I had to deal with at that time. So I had one team which was placed between the patient's legs. Okay, they're in stirrups, placed between the patient's legs. And the second team was operating from the abdomen. And what they would do is they would meet each other. And just as a joke, and it wouldn't be funny in retrospect, but I guess we found it funny then, we would reach through the patient and shake hands between the 2 teams. The result is you live 1 year less by having this extensive operation than just burning the tumor off with a wart burner. They're still doing that today, the wart burner, electrodesiccation. They're still doing that today, but only if you're too sick to withgo this extensive surgery. Then they'll just take it off with a wart burner, or if you insist. So, I just gave you, 2 cases where you just take colon and breast, you just take the obvious tumor. And prostate, you just don't do anything. Look, if something worked, you'd hear about it. There wouldn't be all this controversy. Why do you think you're offered all these options? Why do you think you're offered a lumpectomy plus radiation, mastectomy, radical mastectomy, modified radical? What do you think? Nothing. What do you think? It's because they don't know what to do, because the results are all the same. If it was something that was definitive, like, for example, if you got a stake in your heart, nobody's going to sit and debate whether we should whittle it down to make it look like a flower, the steak, or we twist it around a little bit, or maybe, put some plugs in. No, you pull the steak out and you sew it up. No question about what needs to be done. Well, when it comes to heart disease and cancers and autoimmune diseases and so on, the results of the treatment are either no benefit or more harm than good. So instead of saying, hey, you don't come and see us, you're going to be hurt, and we're going to charge you a lot of money for it too, they lie. I just showed you how they lied. But they've been caught. Okay? You confront any of your doctors or friends or relatives, etc., with any of the research I just showed you. You're not going to get anything but the answer that I just gave you. I assure you. If you do, let me know. You've been lied to by some pretty serious matters. We're talking about deforming your body with a radical or a mastectomy. We're talking about life-threatening surgeries and tests. We're not talking about something that's irrelevant to you. We're talking about whether or not you or your family are going to survive, and whether you're not going to survive intact, whether or not you're going to go bankrupt or not. The number one reason for bankruptcy in the United States is cancer, breast cancer. So you want to change your fortune overnight? You go from somebody who's got a nest egg put away of $250,000. Well, the medical business can wipe that out in a matter of a couple of months for you, a few months. They'll take your money. But for what avail? Show them the research. Look it up. Showed you how to do it. Also give you my email address in case you find something that I didn't share with you. Write me. And you do sometimes, and I really appreciate you writing me. I don't get very much email, to tell you the truth. I'm kind of like the Maytag repairman. Just don't see any reason to talk to McDougall. Either I do what he says because he's going to tell me the same darn thing, or I just don't listen to him anymore. So why come back to see him? I don't know. Why bother? He's just going to tell me the same thing. Yeah, I am. Yeah. Anyway.
So people are asking about other cancers, lung cancer, blood cancer.
Yeah. Well, blood cancers are not solid tumors. Okay, I'm glad you asked that. Lymphomas and leukemias, a few other emias, they're not solid tumors. You can't, you don't find them as a lump. They're spread throughout the lymph system or blood system, et cetera. So those kinds of tumors, there are some treatments that seem to be pretty good for lymphomas and leukemias, not all of them, but a few of them. Testicular cancer, we have a good chemotherapy regime for that. Armstrong was the guy's name? Lance Armstrong. He survived testicular cancer, and so have many other men. So there are a few, and there's also a new class of cancer drugs, which I'm still waiting. They're called monoclonal antibodies. They attack part of the immune system, and they brag that they will cause you to live longer. And the reason they brag about it is because, as they say in their advertisements, is the previous chemotherapy regimes did not show a survival benefit. Regimes that you've been subjected to for 50 or 60 years, they're finally telling you they didn't work. And why are they telling you that? We got one that works. And they probably do, but at what price? I don't know. And this is why I'm kind of trying to learn, reading the research papers, talking story to a few doctors and patients. And, I'm trying to figure out whether I can recommend these or not. Likely I will, because they're for the last stages of life. These are really, really sick people. And any hope that you can offer them is worthwhile. I think they have, I was reading one this morning. It was one of the papers. It's something like an 8-month improvement in survival with these new drugs. 8 months is 8 months, ladies and gentlemen. You only got like 85 years. So eight months would be okay, wouldn't it, if that's all you had to have that extra 8 months. So hopefully it'll turn out pretty well. I bet they're going to charge you a lot. You better get your checkbook ready, because they're going to whittle your bank account down real quick. Even if you got a good insurance, they're going to. Anyway, you know how that goes. And your doctor has to do it, because your doctors are running scared. They're afraid they're going to get sued or be criticized by their colleagues. This is, I call this fear-based medicine. The doctors are afraid. They're afraid of their colleagues and, of course, lawyers. Patients are afraid not to follow the advice that their doctors give them. And the doctors are afraid. They're afraid not to do what is commonly recommended, because whether or not you win a lawsuit depends upon whether you follow the community standard of practice. In other words, if you kill the person the same way the guy or gal down the streets kills the person, you're okay. But if you do something strange, like feed them potatoes and corn and beans, as opposed to treatments that don't work, then you have a, I don't know. Fortunately, I'll knock on wood. I've been at this for about 55 years, and I've only had one complaint against me in 55 years. It was from Veronica Atkins, Robert Atkins' wife. That's it. She got mad because I did a whole national media tour about how her husband died of dietary diseases. Robert Atkins died of heart disease, had atherosclerosis all over his heart arteries and body, and obese and high blood pressure and all these things that Veronica Atkins didn't want talked about in terms of her husband. I understand that, but she went after me, tried to sue me, didn't succeed. But anyway, yeah, I've been very fortunate. That's wood. You know how that goes, because pretty much every doctor gets sued. It's part of the business. So anyway, I like to think that because I have good communication with my patients, And the treatments that I offered are so benign, they cause no adverse effects. I'm just doing something contrary to what my colleagues are doing, that is I'm trying to get you off drugs, not on them. Sick people take drugs, healthy people don't. So, my goal is to get you healthy. And that way you get out of the medical system. You want to be away from doctors and hospitals, etc. You don't want to be involved with these people. Just like you don't want to know morticians or lawyers or CPAs or the plumber. You don't even want to know the plumber, do you? For that broken water main or sewer in your basement. You don't want to know these people. You don't want to know your doctors. That just means you're involved with them all the time. And the way you stop being involved with them is you get healthy. And the way you get healthy is you fix the problem. Do you know what the problem is? Do you know what the problem is, AJ?
It's the food.
It's the food. Oh my goodness, it couldn't be that simple. I mean, good grief. It just seems so simple. It's kind of like quitting smoking stops you coughing. And quitting booze stops you from falling down. Quitting food poisons allows your body to heal. Anyways, it's a wonderful kind of practice that I have. Even though, like I say, I'm as lonely as the Maytag repairman, which is how I got into this discussion. Anybody that wants to write me, I think you'll find that I'm pretty responsive. I've already answered 2 or 3 people in the last 2 days. People who have listened to this show, by the way, and the 5 o'clock show. Wanted further explanation of what I had to say, and it's important to me because I need to hear your questions, because it not only gives me the opportunity to help you, but it shows me where I'm failing in terms of communication.
So there's quite a few questions, Dr. McDougall, and one of them on Instagram from Gilbert is, what are your thoughts on the science of saliva testing for certain cancers and their recurrence?
Well, I only know about saliva testing for hormones. It gives you levels of estrogen, progesterones, testosterones, etc. Well, if you're into hormone manipulation as part of your therapy, I suppose that would be okay. I don't think it does any harm. But unfortunately, what I think happens most often, and correct me if I'm wrong, is that at the other side of all this testing that they're going to do for you, all you got to do is spit in a cup or a whole bunch of supplements they want to sell you. So, if what they wanted to tell you was, yeah, you have elevated estrogens and depressed progesterones, and you ought to change your diet and get some exercise, that'd be okay. But that's not what they tell you. You need more tests. And by the way, we sell those tests, and you need some supplements. And we got the best brand of supplements you ever can imagine. But how about food and exercise? Oh, we don't sell that. That's just too much. That's too radical. All right.
Okay,
so yeah,
sorry.
You can spit in a cup. It's just, I can't see any real value in it. It's not going to do you any harm. Don't buy the supplements.
We had Chad from Datar Cancer Genetics on the show last week, and that is a company that does what's called a liquid biopsy. Are you familiar with that?
Well, I don't know anything about it. But
It's
again,
called True Blood. It's a simple blood test for people that can't get biopsies. It may be because the tumor's in a particular location, or they don't want to have a surgical procedure. They just do a simple blood test, and it can detect cancer.
I think that's the only familiarity I can have with what you just said is there are some testing places that test for common cancer markers, like CA-125 for ovarian cancer. And what they do is they just take a whole bunch of these blood tests that have been studied to see whether or not they're helpful in terms of predicting treatment or outcome. And they've all been failures. So the medical business doesn't use these tests, but because they were considered, there's some evidence behind them, like the CA-125 for ovarian cancer. They put a whole bunch of these tests together that have been declared useless, by the standard medical business, but they're going to sell them to you. That would be my guess. But hey, I don't know about that product, so don't hold me to it. But I have seen other similar testing regimes that just take a whole bunch of questionable valued markers and have you subjected to them and then give you a report based on it. I suspect it's not worth your money.
Okay. Bonnie, who's watching live, would like to ask you if you feel, or would you recommend an endometrial biopsy in her situation? She has been having light bleeding after being fully menopausal for 2 years. An ultrasound indicated a possible fibroid, a cyst on one ovary, and a thickening of the endometrium. And she's been eating this way and lost 80 pounds since 2021 and has no excess weight. And then she has the numbers: fibroid, 1.8 centimeters, cyst, 2.4 centimeters, thickness, 7 millimeters. Would you recommend the biopsy?
I couldn't remember all the details of the tumors sizes, the fibroids, but I think it's my November 2011. No, it's not. I forget which one it is, but anyways, it's about abuse from the medical business. And it was a newsletter about one of my patients. I'll tell you how you find it. You go to Hot Topics under cancer, and it's one of the 3 or 4 articles listed under Hot Topics cancer. Okay, so one of my patients, and this is similar to what you're suggesting, except you have a much earlier condition, which is less likely to be cancer than this woman who had, I believe stage 1, definite endometrial cancer she had, the earliest stages. And, another doctor was taking care of her. He was a gynecologist. And I said, I'd like to see the data which shows that doing a hysterectomy on this woman or any woman would save her life. Well, he couldn't provide it. And I said, look, you guys have been doing this for 60, 70 years or longer. You've done it on millions of women. I said, don't you think you should have done a study? Anyway, she went and got a second opinion. And that's where this story comes in. It was a oncologist from Texas. And this oncologist called me up and swore at me like a drunken sailor. Told me she was going to turn me into my licensing board. She was going to ask the state to take away my license, to be disciplined by my governing organizations. She was going to do all this to me. And finally, when I got her to calm down a little bit, I said, yeah, but can you provide me any of the science that says what you're proposing for this woman will help her, prolong her life? Can you do that? Oh, she was threatened and challenged, to say the least. And she sent me like about 8 papers. And I read the papers. I said, all these papers show that it doesn't work. You just sent me 8 papers that show that it does not work. No survival benefit. What are you doing? Anyway, I told her that I was going to turn her into her state board, licensing board, have her thrown out of the hospital or lose her hospital privileges. But you know what? And I would have done it, except the patient asked me not to, so I didn't. But this woman was so abusive. And of course, she was a specialist, an expert in oncology, which obviously means she knows more than I do. At least that's the attitude that many people take, is I'm the specialist. Well, excuse me, I work really hard to know as much as you do and more. Anyway, you'll find that article interesting. It's worth looking up. Hot Topics under cancer, colon cancer, and cancer. It's one of the 3 articles that are there. And
okay.
All right.
Okay.
What you got there?
So somebody's saying I didn't get their question that was emailed, but I only have one that was sent in advance. So please feel free to type it in the chat right now. Then I will see it. This is a question. Well, somebody's talking about the Moss reports. Are you familiar with them? And do you feel like they're worth?
Yeah. I know Moss. I've known him for a long time. I forget his first name, or I just told it to you.
It's Ralph.
Okay. Yeah, he's written a book. He's been very controversial, written books, and I actually appeared in at least one documentary with him. Thought, he is very critical of the cancer business, and they deserve it. So, what can I say? I mean, I'm not familiar enough with Dr. Moss's current writings to make an assessment, but all I can tell you is he really pissed him off, the cancer business. And, probably still doing it these days, and they deserve it. But I can't say that what he says is correct either. I really haven't looked at it carefully enough.
Yeah. Angela, who's watching live, says her 46-year-old friend had a double mastectomy next week, has a 5-year-old child. What advice do you have for her? She insists I should be getting screened. Why would you be having to get screened if you're not related? I'm confused, but you don't recommend mammographies.
No, I did a whole lecture just now on. No, I don't recommend mammograms. No, there's a book called Truth, Lies, and Controversies on Mammography by Peter Gotsky. Peter Gotsky is his name. Truth, Lies, and Controversies. It's called Mammogram, Truth, Lies, and Controversies. Peter's a personal friend of mine. Actually, he was at our home just before this Christmas. He came to see us. He was head of the Cochrane collaboration for almost 25 years. That's the most respected organization in the world when it comes to providing unbiased information. And Peter wrote this book, and it reviewed the evidence on mammograms and shows how it was essentially dishonest, and showed failure after failure after failure. And I've reviewed this evidence, so I can't speak to what Peter says. I reviewed it, and it was happening when the Malmo study came out. I read the Malmo study. When Miller's Canadian study came out, I read the Canadian study. Okay, when the big New York study came out, I read it. Well, Peter put it all together in this book and came to the same conclusion that I came to while I was reading the papers as they came out over the last, they stopped coming out about 20 years ago. So it was, the 20 years before that, they stopped publishing any articles on mammograms these days because they've already decided they basically don't work as far as saving lives. I just showed you the paper. Do you find cancers? No question you find more cancers, but do you save lives? That's what counts. The only thing that counts is living longer when it comes to this kind of study. So if you can't show a reduction in overall mortality, then you don't work. It doesn't happen. It's not worth your trouble. And these studies, all except for a sigmoid exam, and I explained to you why, show no survival benefit from being screened. There's a lot of money and a lot of controversy involved in this. And I realize that it's easy for you to be persuaded in many directions. But I just want to give you another point of view. And I showed you the science so you can read it. You can challenge your doctors or mother-in-law with it, whatever you'd like. But the stuff I've given you is the majority opinion. That's what the majority of the science says. It's not a minority opinion. Or it may be not a minority based on evidence. Maybe opinion can be anything. All right.
So
Did I answer that?
Yes, a lot of people are asking about HRT, saying it doesn't increase cancer and it might be protective for other things, and people are wondering if they should go on it.
Well, HRT, you're talking about hormone
replacement therapy, I believe. Yeah.
Estrogens, progesterones. HRT has been the hallmark for treating women since it came out in the 1950s. It was originally promoted as this is a drug that will keep you youthful for a lifetime. That's how it was sold to women back in the 50s and 60s. And then they found out that there was an increased risk of uterine cancer, like I think anyways, it's real high. And this general recommendation for everybody to take hormones went out the window because of the harms. Well, what's turned out is that taking HRT does not reduce your risk of dying of heart disease. Taking certain forms of HRT, like medroxyprogesterone, Provera, it's called, increases the risk of dying as opposed to taking natural progesterone. That's in the Women's Health Initiative study. You have an increased risk of uterine cancer that's partially compensated for by taking progesterone along with it, but not fully. You still have an increased risk of uterine cancer, even if you take the combination of estrogen and progesterone. You increase your risk of gallbladder disease by 2.5 times. As I mentioned with medroxyprogesterone, you increase your risk of dying. So let's see, estrogens, they increase your risk of breast cancer. Yeah, they do that too. So HRT, you need to be careful. When do I prescribe HRT? Well, when the women's book is up for free, you can get it, or you can go to the website and buy it for $10 right now. But in the women's book, there's a whole chapter, it's chapter 13 on hormone replacement therapy. And I talk about, various reasons to use hormone replacement therapy and various reasons not to. I never give HRT with the attitude that's going to give you a longer life, because it won't. I gave HRT to treat symptoms. All right, that's it. Like if you came to me and you said, I have uncontrollable hot flashes or poor feelings of well-being, I feel, since I've lost my hormones, I get depressed all the time. And, if you came to me with that approach, I would say, okay, let's try some HRT. See if it relieves your symptoms, makes life a little easier for you during the 2 years that most women have difficulties with menopause. It only lasts about 2 years. All right, so we'll try a little HRT. And in chapter 13 of the women's book, the McDougall Program for Women, I talk about how I prescribe it. And I prescribe it as skin creams, combinations of estradiol, which is the hormone women make when they are in their reproductive years, and with a little bit of progesterone, natural progesterone, not medroxyprogesterone, but a natural progesterone. And I recommend that to treat symptoms. The other way that I use HRT is if women want to fool Mother Nature, and they often do. And that is, you want to have sex past your time of reproduction. You see, nature says, look, in fact, we're one of the only animals that, one of the few animals that has sexual relationships after the time of reproduction. Plus, we're one of the few mammals that have something called the grandmother effect, which whales have. There's certain breeds of whales, and human beings do, which is where you don't die when your reproductive life is over. All other animals die when they're done able to reproduce, but not those who have the grandmother effect, which is whales and human beings. Why do you have the grandmother effect? Because it improves survival. It's a better chance that your family will survive having grandma around to help. So, I don't know, how did we get into that HRT? What'd you ask?
Should people take it or not?
Oh, yeah, for symptoms. You take it for symptoms. That's it. Oh, I know what I was gotten to tell you. If you want to fool Mother Nature, and Mother Nature says there's no reason to have sex after you can't have babies. Well, some of us human beings feel differently. I shouldn't include myself, but some people feel differently about it. And if you're in that type of situation, then you've got to counteract some of the things that occur naturally when you go through menopause. Your sexual desires change. And by the way, they sometimes increase in women who go through menopause because you have this balance of testosterone and estrogen that affects you throughout your reproductive life. Well, when you go through menopause, the ovaries stop making estradiol, which leaves testosterone as a dominant hormone, which is the male hormone related to libido. And so often women during their time of menopause or right afterwards will have an enhanced sexual libido. But you run into another problem, and that's the problem of vaginal atrophy. Because there's no reason to have a strong birth canal, what happens is the birth canal, the vaginal tissues become thinned. You know, they go, I remember when they go from 7 cells thickness to 1 cell thickness. That could be wrong, but I remember that from someplace. And that's due to lack of estrogen. And so what I will do is I will prescribe estradiol as a vaginal cream and ask women to use it because it's not associated with any increase in cancer. It is associated with a decrease in fractures, which is a positive effect from the estrogens. Plus, it builds up the vaginal tissue so that intercourse can be better accomplished. You know, so that's why I would use it. And how do you use it? Well, I'll have a woman use it every night for a week, or until things seem to be better, and then to reduce it to maybe once or twice a week. Or another thing you can do is if you have a life that's planned, and like for example, you say you're going to have a date. Let's have a date in 2 weeks. You can just take the estrogens, vaginal estrogens, just the week before, 3 or 4 or 5 days before, and it'll toughen the tissues. So you don't have to take them all the time. You just take them whenever you have a date, which could be twice a year or twice a day. Who knows? Yeah.
We've had several urogynecologists on the show that recommend it for prevention of UTIs.
I don't know. I think it probably doesn't help. I would like it to help, but what I remember is, well, estrogen has been used for incontinence, and it doesn't seem to work there. I don't know.
I could show you some research. I could share with you their research.
I guess I'm not familiar enough with the infection data to make a comment on it. So but I would be surprised.
I can show you some of the data that they've shared with me on that.
Well, all I want to see.
They call it the genitourinary symptoms of menopause. It's for menopausal women.
Yeah. Well, like I say, you just show me randomized control trials. I'll be happy.
Okay, I'm going to actually
an observational study.
Okay, randomize. Okay, I'm going to text one of them. Okay, you want to see RCTs? Okay, I'm going to text one of the doctors.
When I'm not familiar with something, hopefully I'll admit it to you.
I am going to text one of the doctors as I ask you this next question from Marley. When you have blood cancer, other than diet and lifestyle, are there any alternative treatments you would recommend?
There are all kinds of chemotherapy regimes out there for lymphomas and leukemias. And again, I'm not familiar enough with the different types of leukemia or lymphoma that is responsive to a certain type of chemotherapy. I'd have to spend an hour or two looking over that research again. I can't remember all of it.
It's okay.
So blood tumors are different than solid tumors. Yes, we've been talking about solid, the solid mass lump tumor, blood, every place. That's what we're talking about, solid tumors.
Thank you. Any advice for those that are positive for BRCA2 breast and ovarian cancer gene?
Yeah, don't have your breasts removed. There's no survival benefit from doing a mastectomy with BRCA. BRCA, by the way, stands for BR is breast, CA is cancer. Well, not the fanciest name for this particular genetic variation. There's BRCA1 and BRCA2. And what the advantage is to having these genes, I don't know, but there may be. There may be. And what we know is that when women have a BRCA gene, they're offered prophylactic mastectomies and or removal of the ovaries. And I'm here to tell you, taking the breasts off is not going to make any difference. but taking the ovaries out will. Why? Because as I started telling you at the beginning of this hour, estrogen is a big deal when it comes to progression of hormone-related cancers. So if you take the ovaries out, you reduce the estrogen, which prolongs survival. Well, why go through the mutilation, amputation of a mastectomy when it's not going to do any good, but you will be offered it? When the only positive benefit is going to be removal of the ovaries. Take the ovaries out. I do recommend that, as I do for women who have breast cancer in general. You know that. My general recommendations are lumpectomy with clear margins, no lymph node biopsies of any kind, no radiation of any kind, no mutilating surgery of any kind, if you can avoid it, and a good diet and anti-estrogen protocols, which are tamoxifen, aromatase inhibitors, or removing the ovaries. Now, there's another way that you can remove the ovaries, which I want to talk about. All right. The other way you remove the ovaries is you kill them with cancer chemotherapy. Right. The studies that show a benefit from cancer chemotherapy are ones that, in these studies, what they show is the benefits were limited to women who still had hormone function. And so what you did is you made them so sick that you destroyed their ovaries. And as a result, you reduced their estrogens. My contention is there's a much more humane way to remove ovary function, like through a laparoscope, as opposed to making a woman lose her hair and throwing up for a year, which is chemotherapy. That's why chemotherapy works, if it works at all. It does go out and catch the tumor, kills the ovaries. Love to show you the data on that.
Thank you. And somebody's asking about lung tumors. Leave them alone?
Well, that's a pretty big general question. In general, there's been no reliable evidence that removing a part of a lung or a whole lung with lung cancer prolongs survival. But there's absolutely no question that it causes terrible disability to try and run around with half your lungs, or at least a big portion of them missing. So it's a big deal. So you better show some survival benefit from going through all of this extensive treatment. And my question to anybody who recommends surgery or chemo or radiation is, show me the data. Show me the randomized controlled trials. And you should have done them. You've been treating hundreds of thousands of people with lung cancer over the last 50 years. Why have you not done the studies? Show me the studies that show treatment results in a longer life, a reduced mortality compared to no treatment. I just showed you the paper that said it didn't. JAMA Oncology, I just showed it to you. There's no survival benefit from early detection from lung cancer. And as far as removing it, I've explained to you why removing it doesn't make any difference. It's at least a 10-year-old disease. Now, the problem is with people who have tumors discovered when they weren't even looking for them. These are called incidentalomas. In other words, I was looking for one thing, and incidentally, I found something else. Incidentalomas. These are common. In fact, if you do 2,000 CAT scans, you'll find 1,300 abnormalities. You want me to go through those figures again? 2,000 CAT scans, 1,300 abnormalities. In other words, you are subjected to a threat of further testing and treatment. Be careful what you ask for. Anyway, the other thing what I do with people with lung cancer, HASI, because it's such a brutal operation with such poor outcomes, it's such disability. What I recommend is, prior to surgery, to committing yourself to surgery, is that you see if the tumor's growing or not. You take serial CAT scans. The tumors double on average every 100 days. So if you take one CAT scan today and you take another one 3.5 months later, if it didn't double or didn't change at all, it's likely not a tumor that's going to threaten your life. And especially if you took another CAT scan 3 months after that and another CAT scan a year after you were initially diagnosed, if it still didn't grow, leave it alone. It's not going to grow. Hasn't grown in a year, not going to grow.
What if it does grow?
What if it does? What if I get struck by lightning? Get run over by a car? Could happen, you know. I can't play that game. Yeah, you're right. You could have one of those tumors that stayed tiny and still metastasize, and they do that, by the way. They do, but it's already happened by the time you find it. That's what you have to realize is the natural history of these solid tumors is by the time you find them, on average, they've been doubling for 10 years. This includes lung cancer. In fact, lung cancer was how this was originally discovered. This was in the 1950s. What they did is they took a bunch of people who died of lung cancer and they looked at their previous chest x-rays. And they said, we missed it last time, but I can see it right here. Okay, we missed it 5 years ago, but I can see it right now that I know that this is where I can now see it. I read it as negative last time, but now I can see it. And then you see how big it was 10 years ago, 5 years ago, 2 years ago, and you see the change in growth. The tumor size, it's the diameter of the tumor. This is two-dimensional. Okay, that's what x-rays are. They're two-dimensional. So the diameter of the tumor, what we see it going from tiny to big, and the doubling time is every 10 years. Excuse me, every 100 days, the doubling time. The doubling time is every 100 days. And it takes 10 years before it gets big enough to find it. So, if you want to play the hunching, the guess and hunch game, fine. You can do that all day long. If you want to listen to the science, then you're going to listen to the truth. As we know it, it could change. But as we know it, you have to look at properly done research to decide. At least I do. I know other people, I like my doctor. I don't want to offend him or her. Good grief. If I said no, what would the doctor think of me? Who cares? You hired this person. It's like hiring a plumber. Who cares? Go hire another one. These are doctors. They're just people. And they have the same flaws and positive things in their life as everybody does. They're no different.
Are you familiar with mistletoe?
Ooh, talking about the kissing time.
Well, no, Linda's talking about
I know mistletoe has been considered to have a lot of positive benefits. I don't know what they are. I have been so long since I've looked it up. But again, if we're talking about cancer and mistletoe, the questions I would ask are this: will it kill me? The answer is no. Well, will it cause terrible side effects, cost me a ton of money, or take an exorbitant amount of my time? Likely no. It's probably fits all of those in a positive way. Cheap, few side effects. It takes just a second to take a pill. No big deal. And so, if it's not going to kill you and it's worth your time and effort and money, put it to the test.
I think
okay. So you're talking about taking mistletoe. Huh?
I think it's an injection, if I remember.
Okay, maybe. Again, it's been a while. I think. Well, anyway, I'm not going to talk about something I don't know. But anyway, if it meets those criteria, what you want to do is give it a try. So let's say you're dealing with a tumor. Let's say a tumor. Let's just pick the lung. So you start the mistletoe, And, hopefully, I don't know if you can do it if you haven't seen any growth in the past. So you got to have an actively growing tumor. If it's not growing, then you can't do the test. But let's just say it's growing. Then what you do is you take the mistletoe and you get another CAT scan or whatever, 3.5 months, 6 months later, and see if it's made any effect. And then better yet, you take 1,000 people and you do a randomized controlled trial on them, which is not going to be done because there's no money in mistletoe.
Colleen would like to know, what do you think about repurposed drugs for cancer? Fenbendazole for one, fenbendazole.
No, I doubt it. Yeah, repurposed is called. I think they're called gray prescribing. It's where doctors are allowed to prescribe pretty much any drug for any condition, even if it's not indicated for that condition. It is, using a pill that say treats leg cramps, to treat your high blood pressure. Well, the doctor's allowed to prescribe this. So repurposing drugs is kind of like clinical trials. Don't do it. Don't buy. Look, if it's worthwhile, there ought to at least be some research done on it. So.
Okay. Would you take a question that's not on cancer?
Yeah, sure.
Oh, thank you, because this one was sent in a while ago from Anna. Someone with gallstones who's experienced a gallbladder attack, how do you determine whether they can save the gallbladder or if the gallbladder needs to come out?
All right. Good question. You can look up the data. You look up under PubMed or Google or whatever. You look at treating asymptomatic, that means without symptoms, gallstones. And you look for controlled trials where they have found gallstones and not treated them. They had no symptoms. Incidentally, you could find gallstones if you got an abdominal x-ray, a chest x-ray, a sonogram or something. You find out, and a lot of people have gallstones, like women, middle age, 40-year-old women who are overweight, about 40% of them have gallstones. So it's not hard to find. And they never bother them. They're not hard to find asymptomatic gallstones. And you want to keep them asymptomatic. And the way you do that is you eat a low-fat diet, because that's the time-honored treatment for gallbladder pain, inflammation. And when you compare the difference between those who don't treat with surgery, asymptomatic gallstones, as opposed to those who immediately send the patient off to surgery. I'm familiar with a lot of studies, and all of them I'm familiar with show there's no benefit to treating asymptomatic gallstones. Immediately treat them. You should leave them alone. There'll be something for the medical students to play with during their anatomy lab when you donate your body for medical reasons. Medical students do that, fill the gallbladder, look stones. Anyway, bad joke, right? But they do. I remember.
Nice. Okay. Advanced T cell follicular helper non-Hodgkin's lymphoma.
Too specific. I couldn't tell you. I'd have to look it up.
All right. Jeanette is asking for her partner being diagnosed with that.
But I've told you how to do it. Okay. Just because I don't have the memory or the past experiences doesn't mean you can't have this information. Just go to the National Library of Medicine, go to Google, look it up. And I've showed you how to get studies that aren't even available to you because they charge you for them, or they're not available, period. Just go to Sci-Hub, SCI-HUB. They're all there free. You need to put yourself in a situation where you sit down with the doctor, and after 5 or 10 minutes, the doctor looks at you and says, ma'am, you know as much about your disease as I do. And you say, yeah, this is my disease. I better know more than you do, or at least as much. You become an expert on your problems and then figure out how to most safely treat them.
All right. I'm 24 years old and I've had glomerulonephritis since I was 17, which does not respond to immunosuppressants. I have high proteinuria. Can your diet plan help?
Yes. Where do you find the data on this? We're giving you the free book, okay? McDougall's Medicine, A Challenging Second Opinion. The whole chapter on kidney disease. Plus, in 2013, the New England Journal of Medicine published a study on kids with nephrotic syndrome. Glomerulonephritis leads to nephrotic syndrome. They took these children who had progressive kidney disease, and they did biopsies on their kidneys, and they found that the kidneys were being attacked by antibodies that were produced as a result of drinking cow's milk. You see these beautiful pictures. It's in 2013 in the New England Journal of Medicine. Look it up. It just put in milk protein or cow protein and glomerulonephritis. Shouldn't be hard to find. So you see these beautiful pictures of these antibodies that are directed to cow's milk attacking the kidneys. And then they took 4 of the children off the cow's milk, and guess what? They were all cured. Published in the New England Journal of Medicine. Has this changed the practice in your community? No. I bet 99% of your pediatricians and family practitioners have never heard of the study. Yet, if you went to the doctor, that should be the first thing you'd be offered, don't you think? Get rid of the cow's milk. I also have studies, and you'll find them in the medicine book that I told you about. I believe there's a study there on pork protein being found in glomerulonephritis, and pretty much any animal protein can be involved. So yeah, you go on a healthy diet. Now that's just the actual disease, okay? Now there's a whole nother level of benefit besides the disease. Even if you can't stop the disease, even if all the damage is done, there's a whole nother benefit to changing your diet. And that is, it's been known for probably 100 years. Addis, who's the father of nephrology, reported on it about 90 years ago. He said that that you slow or stop the progression of kidney disease by putting somebody on a low protein diet. So if you go on a low protein, like ours, of course, particularly a low animal protein diet, because animal protein is much more destructive to the kidneys than vegetable protein. If you go on a low protein diet like ours, just because of the flows of the kidney, not related to the underlying cause of the kidney, this could be a benefit that's seen in somebody who donates a kidney. And so they have half the kidney function left, they just gave one away or got in an auto accident. You see these same benefits. Eating a low protein diet slows or stops the progression of kidney disease, and it'll clear up proteinuria. Always no. Improve it? Yes. Yeah. And there are multiple studies done. You will find these studies in addition to that book. If you go to my website and you look under Hot Topics Kidney Disease, you'll find an article titled Diet and Kidney Disease. It's about a 7-page article with pretty much updated scientific evidence, because I wrote it probably 10 years ago. I wrote the book like 1984, I published it. So in there are updated references telling you about the studies that have been done on how diet causes nephritis, nephrotic syndrome, glomerulonephritis, whatever you want to call it, proteinuria, whatever, inflammation of the kidneys, whatever. It's caused by food. Not always. There are certain bacteria that can lead to these kind of antibiotic reactions and toxic chemicals and stuff, but food. It's mostly the food. Not only causing the disease, but stopping the disease. And also, in addition, totally unrelated to stopping the disease that improves the flows and pressures in the kidneys and keeps them alive longer. The kidneys, they stay with you. You can slow or stop the progression, regardless of what causes your kidney disease, whether you, like I say, lost it through surgery, lost an auto accident, got an infection, regardless, it doesn't matter. Polycystic kidney disease, doesn't matter. You eat this kind of diet and your kidneys will stick around a lot longer. And hopefully you'll avoid dialysis and death for a while, or at least death for a while. Death always comes.
Right. Christina wants to know, what do you think about vibration exercise machines that claim to assist with lymphatic drainage?
Well, from the reports I've seen on TV, it's fraud. Oh, come on. I certainly would have to go do the research, but the reports that I remember about jiggling fat and these, the where they have belts, the leather belts that went around your belly and jiggled you, just nonsense. I guess that's a lazy man's way to exercise. It doesn't work. You don't see them sold anymore, do you? Not much. Man.
Yeah. A lot of people are wondering your thoughts on vaccines, particularly shingles and pneumonia.
Mary and I have both had both vaccines. We've had both the older pneumococcal vaccine and the newer one. We've had them both. We've had shingles injections at least twice and maybe 3 times. I believe in vaccination, except, I'll tell you the except in a minute. All of our family is immunized for hepatitis A, B, diphtheria, polio, I think probably chicken pox and measles. And they've got the full spectrum of immunizations. Why? Because vaccinations work. They've changed the course of human health. And only 3 things have done that. And they're better sanitation, better nutrition, and vaccination. Only 3 things have changed the destiny of human beings and the population. So why would you throw the baby out with the wash water? Well, only if they don't work. And they don't work sometimes, like with COVID and with influenza. And you know that. I mean, sometimes 2 or 3 times a week, they come out and they tell you there's a new variant. New virus. Vaccines don't work. Oh, no, they say there's some protection still given, but they really don't deal with that specific infection. So you really ought to get it anyway. There's always a byline in there to try and tell you, even though the studies fail to show a benefit, we still think you ought to buy it. Anyway, flu vaccines, same thing with COVID. The viruses have an ability to what we call genetic drift or modification, or you know it as variants. They have this ability to rapidly change their structure, to adapt to the environment. And unfortunately, the vaccines are made for the last virus, the one that was here 2 or 3 years ago with influenza, or the one that was here 3 years ago with the COVID. But that's not the same virus that's going around today, Doc. Well, of course it's not. Well, why should I get the vaccination? Well, you shouldn't. So our family does not get COVID vaccines. And I'm open to changing that. Believe me, if they get a good vaccine out, I'll get it. But right now, they don't have a good vaccine out. The same thing with flu. Flu shots are pretty much useless, but they're going to give you 10% off on your groceries if you buy a flu shot. Don't they do that? Don't you just wonder why there's a big sign out in front of your grocery store that says that we'll give you 10% off on your groceries if you take the flu shot? Don't you think there's some financial motivation here? How do they link my vaccinations with me buying ice cream? Which I don't do.
Yeah. That's interesting. But at first,
by the way, I want to go so far as to tell you that monkeypox, Mpox they call it now, is the same virus as is smallpox. I have had smallpox immunizations. I'm at an age where we used to give those routinely. They give a little poke on your arm. So I've been immunized for smallpox, but my children haven't, neither have my grandchildren. And chemical warfare, biologic warfare is likely to involve smallpox. So you say, well, there is smallpox. It's in banks someplace, in laboratories, but the virus still exists. And it's considered as a main virus to do biologic warfare. So do I want my children protected? Yeah. And grandchildren? Yes. Will I give them monkeypox vaccine if I could get it? But since it's the same as smallpox vaccine, would I do it? I'm not telling. But if it was easily available, I probably would, but I haven't found it. So. Mm-hmm. Yeah, don't throw the baby out with the wash water. You got all these conspiracy theorists out there, and they deal in lies and alternative facts, we call them.
Mm. Somebody's asking if yam cream is safe.
Yes. Yams, progesterone is made from yams. And so what they're talking about is a progesterone cream. So from a yam extract, it's probably concentrated natural progesterone. So yeah, I think it's safe. You can buy it over the counter. You can buy it in your local grocery store. You get natural progesterone cream. It is the same cream and the same potency as would be prescribed by a doctor. It is supposed to reduce your risk of uterine cancer, especially if you take estrogens, and it also may reduce your risk of breast cancer. In one study I have, I don't know where I may have put this in the women's book, I forget. But one study I have, they did a biopsy of women's breasts, and they found hyperplasia, which is a precancerous finding in these breasts. And then they were taking estrogen. Estrogen. They were taking estrogen creams. I believe it was a cream. And they had precancerous changes in the breasts. And then they added progesterone, and it reversed the precancerous changes. I've got it someplace. Most of it burned up in the fire. But there is such a study done.
Do you know what RKK testing is? Angela's asking if she could get it or should get it.
RKK? No, I don't.
Yeah. Sorry. People got to be more specific. A lot of people are saying they like your shirt.
Oh, good. Isn't that nice? AJ gave me this.
I love it too.
I wear it. I wear it quite often, even when I'm not trying to impress her.
What do you think about tetanus shots and tetanus boosters?
Yeah, as I say, there are only 2 vaccines I won't take. But yeah, I've seen tetanus, ladies and gentlemen. I watched a guy die of tetanus. I've seen polio. I've seen people on iron lungs. These are real to me, not to you, I know, but they could be tomorrow. You don't know what the world's going to be like tomorrow. Even though, things are pretty safe right now. What about tomorrow? I think you want to get your family as prepared as possible for tomorrow. And that would be fully vaccinated with all of the vaccines that work, and a good diet, a little exercise and sunshine. Be as healthy as possible for whatever is going to happen in the future. And one of the things I'd like to add here is that people who catch COVID, the virus, those who are in poor health end up in the hospital on a mechanical ventilator, drowning in their own fluids, their own lung fluids, and eventually dying. But it's those who are sick with comorbid diseases like obesity and diabetes and heart disease and the things that we cure. So, if you want to set yourself and your family up for the future, even if it's going to be a virus, there's obviously a virus. What you eat makes all the difference in the world. If you watch the newsreels, TV, I call them newsreels, show you all that. We watch the TV segments and they go in and they visit somebody in the hospital who's dying of COVID. What do you see lying in the bed? An obese person. You know, unless you've got these comorbid factors, the COVID is a relatively benign disease. Not always, but most cases, you end up with, you know, nothing worse than the flu. You don't get hospitalized. You don't end up on a ventilator, and you don't die from it. You just get over it. Which, of course, brings me to long COVID, which somebody's going to ask me about, which I don't know anything about. So forget it. Don't ask.
Dr. McDougall, I texted the urogynecologist and the urologist who recommend vaginal estrogen for recurrent UTI prevention in hypoestrogenic women. And I've got the medical research article. I can put it in the chat if you want to take a look at it. How do I chat?
Well, why don't you just tell me whether it's a randomized control trial or not?
Okay. Shoot, it looks like I have to. It
You'll
looks
say
like,
so in the first sentence.
you know what? It's behind a paywall, and I'm boy. It's
well, you know, I'm really only interested in randomized control trials. Okay. Observational trials are so easy to bias. So it may be, if it is, fine. You know, then you know what I'm going to ask is, where's the confirmatory research? Because things that work are usually tested by another group to confirm whether they work or don't. So give me the initial data, give me the rationale behind it, give me the safety protocol, and give me the confirmatory research. And then I'll feel pretty good about recommending it. Right now, I don't have that. I don't know. But
yeah, I can't. I'll find out.
Let's see.
It's
Anyway,
from the American Journal of Obstetrics and Gynecology, but I'm not a member, so I can't sign in. But a lot of women say it's helped them never get another UTI.
Well, let me ask you, do you have was it published before 2023?
It was published August 10th, 2023.
Well, it won't be easy for you to find then. I was going to say you could go to the Sci-Hub and pick it up.
Yeah, there's something in PubMed about this, the efficacy of vaginal estrogen, but I can't, in the studies, the results, I could show you that one. 5,600 women were prescribed for the treatment of recurring UTI, and it decreased more than 50%. And yeah, I don't know.
Well, anyway, where's the control group?
I don't know. And maybe there was one, maybe there wasn't, but I'm sure she'll get.
If there wasn't, then I'm really not interested. Okay. You know, I mean, I find it of interest, but it really isn't enough for me to feel comfortable.
But how can you do like a randomized controlled trial, like things with cancer, and like, because
you take 500 women, you have 250 of them use the estrogen and 250 don't. And you find out what happens over a period of time. You count the number of UTIs they have, and what you find out is at the end of the study period, those who took the estrogen had the same number, more frequent, or less frequent attacks of urinary tract infection. That's the way you do the study. If you just sit until you take 550 women, which, you know, I would guess this is a randomized controlled trial that you're telling me about, because I don't think the American College of Gynecology and Obstetrics would publish otherwise. So I don't think they'd publish an observational study. So it's probably a randomized controlled trial. Anyway, you know, I think that would be a reasonable thing to prescribe. As I told you, I prescribe vaginal estrogens. And if it helped with recurrent vaginal infections, I'd like to know that. I actually can think of a person you and I both know.
Yeah. And I've told her to take it because it's worked for a lot of people.
I have too. Okay, I've actually been recommending this person use vaginal estrogens for the last 5 years.
Oh.
So even not knowing that study, I have a patient that you and I both know that I made this recommendation.
I've begged her because there's been so many times she can't do anything because she gets these painful recurrent UTIs, and I started taking it for that and I've never had another UTI. I was misdiagnosed 2 years ago with interstitial cystitis. It was just a UTI. I was getting them all the time. And the minute I went on it, I have not had a UTI in 2
Do you
years.
use it vaginally or do you use it on the skin?
It's vaginally, and I see the cream is yucky, and that's why a lot of people don't like it, but it's like a pellet and it's like twice a week.
Okay. Well, as I told you, I use vaginal estrogens.
Yeah. I think a lot of people don't like the cream because it's bleh, but it's like a pill. It's like a little pellet.
Well, that, yeah, that's good.
Yeah.
So
Anyway, I wish our mutual friend would at least try it because she suffers greatly. But you can't do randomized control trials for things like cancer because then half the people wouldn't get treatment if they wanted it.
well, Bernard Fisher did a randomized control trial in 1970. And the study done in 2023 was a randomized control trial with or without radiation for lumpectomy. So the studies I showed you are all randomized control
Wow.
trials. Everything I showed you was a randomized control trial with a large number of people. So I rely on that kind of research. I would expect other people to do that too. Or if they don't have it, say, look, I don't have the research to support what I'm telling you, but I believe it's true because of my experience. And then you know where the information comes from. It's my belief. It's not based on science or data, but it still might be right or it could be wrong. The reliability of what you're saying increases as you do a better scientific study method. And if you have a whole bunch of randomized control trials, like there are about 25 of them on heart surgery and survival, and they all show that there's no survival benefit to doing angioplasty, all of them, and the ones for open heart surgery are pretty similar. You don't live any longer, but they keep doing them. I think they're finally done now. I'm pretty sure they're done with the heart disease treatments because I saw an article. Again, it came out I should find that article. Came out a couple of weeks ago, which, basically admitted defeat, that we shouldn't be doing these heart surgeries anymore. I hope I can find that article, but big publication, just showing me that the cardiologists know better too. They know it doesn't work. They should stop doing it, but they won't because they make a lot of money. A lot of money, like $1 million a year doing these things.
Yeah. Here's an interesting question from Stephanie. What causes a UTI?
Well, there are lots of causes, and one of the more common ones is called honeymoon cystitis, which is where your partner is not conscious enough to be careful and traumatizes your urethra during sexual activity. And as a result, the urethra becomes swollen and the urine backs up and becomes stagnant and the bacteria grow in it. You get a UTI. So what's recommended for honeymoon cystitis? Well, assuming you don't want to give up physical relationships in the vaginal area, you don't want to give that up. What can you do about it? Well, the recommendations are, well, first of all, the partner needs to be careful. All right. You can't go banging around in that area like it's, anyway, I don't even want to give an analogy, but you can't do that. You got to be kind and gentle, aware of what's going on. Well, that's the first step. The next step would be to urinate after intercourse. That's recommended a lot. And then the other is to take cranberry pills or juice either after intercourse or all the time, or to take antibiotics, doctor-prescribed antibiotics, after intercourse or all the time, depending upon what's called for. So that's honeymoon cystitis. And then, vaginal atrophy that, I just don't find many postmenopausal women getting recurrent urinary tract infections. So, yeah, it's just not been my experience that this occurs very often. I now obviously know 2 people now, but I knew only 1 before.
Okay, cool. Baby vaccines.
Yeah, except I think they do them too early. You know, again, I'd have to, you can look it up. You can look up, I think I talked about it. If you go to Hot Topics, you go to children and pregnancy. The first article is the children are our future. And in there, I talk about how to feed children. Yeah. So, anyway, what was the question?
Baby vaccines, Randy wanted to know.
I think that I may have said it in there. I believe it was the diphtheria vaccine that I think they should recommend later on, as opposed to early. But again, it's been a long time since I wrote that and even reviewed it. The last baby I had was almost 40 years ago. So, but yeah, I think all our children were immunized, vaccinated. And I think I did delay the diphtheria by a year. So, but again, don't hold me to that.
Thanks. Becky says, will the diet help with aplastic anemia?
In one way, and that is whatever wrong with you, you need to eat well. You know, even if you break your foot, you need to eat well. But as far as it correcting aplastic anemia, I doubt it. Most aplastic anemias are due to toxins, drugs, medications, that radiation. You know, what you do is you destroy the bone marrow, and those cells are gone, and they don't come back. So, you know, that way if you destroy your foundation of basic cells, reticulocytes, etc., the progeny where all other cells are derived from. There's a family of cells that lives in your bone marrow that produce other cells like red blood cells and white blood cells, etc. These basic cells live in the bone marrow. Once they're destroyed, they're gone. They don't come back. So you want to protect yourself from anything that would be toxic, drugs, medications, environmental contaminants, etc., radiation cause aplastic anemia. And probably a few others too.
What do you recommend for aftercare from a double mastectomy?
Once you're done with the doctor, don't go back. I'm serious. You know, after you're done with any kind of surgery like that, lumpectomy or double mastectomy or whatever, what they'll do is they'll schedule follow-up visits for you. Well, you need to ask why. Why do you want to follow with me, doctor? I mean, if you have any treatments that are of value to me, why don't you give them to me now? What are you waiting for? The answer is they're waiting for nothing. They've given you everything effective. But why are they seeing you all the time? Because it's so disturbing. Doc, I got a follow-up appointment at the end of the month. All I do is worry about that appointment for the next 2 weeks. Not only do I worry about going to the appointment, but when the doctor looks at my x-rays and blood tests, I'm sure he or she found something wrong. I just know by the twinkle in their eye, by the way that they smiled, there's got to be something wrong, but you don't know because the doctor's not ready to tell you. So you go home, and for another 2 weeks until you get the final reports, you worry about it. And then you don't believe the reports, they must have missed something, you worry about it. There's no reason to follow up. In fact, it's an official recommendation from the medical literature to not do follow-ups with that kind of surgery. You need to eat good. If something comes back, you know, there's not much you're going to do about it. If it comes back locally, like in the breast, for example, I mean, you're still on your chest wall, even though they took most of the breast tissue, there's still some breast tissue there. So you could get a cancer occurring, but you'll feel it. You don't have to go looking for it. It'll be obvious. It doesn't matter whether you find it before it appears under the skin or afterwards. It's already at least a 10-year-old disease. It's already every place. So, no, you should stay away from these people because they'll have more tests and more treatments to recommend to you. It'll ruin your day. You're going to spoil at least an afternoon taking the day off from your family or your work to go and visit these people. So anyway, I think I was clear.
Yeah. This question from Sylvan just says heart valve surgery. It's not very specific. I'm guessing they're
Well,
asking,
that's a hard one. There are
is it
lots of
worth it
help.
for an elderly person to have it? Thank you for clarifying.
Well, yes, I think if the person has a significant number of years left, functional years, and is in good enough shape to survive the surgery, that they could make all the difference in the world. There are a couple of ways to do valve surgery these days, and I'm not going to get into the controversies much, but the way we used to do them is through the chest. You put a hole in the sternum, and we put either a cow or pig valve, in other words, taken out of a cow or pig, or a mechanical valve called a Starling valve. We put that in there. Now, the Starling valve was kind of interesting. It was a wire cage with a ball in it, so that every time the heart beat, the ball would go up and let the blood go to the body. And then when the heart wasn't beating, the ball would fall back into place and prevent backflow. So you constantly bing, 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 all day long, bing, 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 bing. You drive you nuts. Anyway, they don't use that much anymore. There may be a few holdouts, but I don't think so. But they use pig and cow valves, which are good. It can make all the difference in the world. But there are a couple ways to put them in. You can put them in through the chest or through the leg. This is a trans-aortic something or other. You'll be able to figure it out. They just take a catheter and they stick the catheter up through the aorta and do the surgery through these instruments and stick the valve in place without any open chest surgery. This has become the preferred way to do things. Why? Less trauma, great outcomes. But there's territory that needs to be defended by those who do the old surgeries. And so they're going to fight them tooth and nail to preserve their business. And that's what's going on right now with these valve surgeries is we have two camps, those who do the brutal open heart through the chest wall replacements and those who do the transcatheter ones. I'd go transcatheter, old or young. And it's been somewhat limited to old people, by the way, and not young. But these days, it's recommended for more and more people, the trans aorta type, because, well, obviously, it's less of a surgery, tremendously less.
You mentioned that the people that have the surgery when they're diagnosed with the BRCA gene, you said that there's no greater survival rate. Why is it recommended then, and why are the women doing it?
Well, I don't know why they keep doing it, because they're not told all the data. Okay, so when you have BRCA 1 or 2, remember it's BR, breast, CA, cancer. No big deal as far as making the acronym. BRCA 1 or 2. You have an increased risk of breast cancer and ovary cancer. Okay? However, taking the breasts off will not make you live any longer. Taking the ovaries out will make you live longer because they produce estrogen, and estrogen promotes the progression of breast cancer. So by removing the ovaries, you get all the benefits you're going to get without the mutilation. You get to keep your breasts if you were told the truth. But hey, lady, you're going to have high risk of breast cancer. You got a high risk of ovary cancer. We're just going to get rid of those organs, so we'll fix you up real good. Don't have to worry about it anymore. Not true. You just have a reduction in your risk of dying of these diseases, but that reduction is fully because of the the oophorectomy, the taking of the ovaries, has nothing to do with mastectomies. You just mutilate it unnecessarily. You want to see the science on that? Look it up. I've got it.
I was at a potluck yesterday and there was somebody who's actually, I think, a little bit older than me that had all those surgeries. And, probably not a good idea to tell her what you said and make her feel bad that she had it, right?
Yeah, well, that's what that's what you'll be offered. Pretty much less things have changed since I last looked. You have nearly 100% chance of losing both sets of organs when only taking the ovaries will make a difference in survival. You know why, don't you? I told you why. I explained to you why. In the beginning of the lecture I talked to you about the power of estrogen in terms of survival. The treatment of breast cancer involves decreasing estrogens, tamoxifen, aromatase inhibitors, oophorectomy, and cancer chemotherapy, which is I offer only jokingly. So, I've told you about that in the beginning of the lecture. And so you know why taking the ovaries out makes a difference. It does for all women with breast cancer or without breast cancer. If you have your ovaries removed, let's just say you have your ovaries removed or you don't have ovaries, you're born without them, your risk of breast cancer is 0. Okay? So, it's a hormone-dependent disease.
Yep. Can you stop the progression of heart disease with a plant-based diet if you're that CAC score of 69?
Yeah, that's not big. That's no big deal. Mine was 200 or 330 when I got mine done. Still alive.
Yeah.
I had a heart scan done on me about 35, 40 years ago when my brother, who's a board certified internist, was working in a medical group that had a heart scan. And so Mary and I both had heart scans. And the technician called Mary in first and said, I'd like to talk to you first. And she said, yours is beautiful. She told me, yours is beautiful. And then she called me in and she says, I think your next stop ought to be the heart surgeon. You're in big trouble, buddy. I had a calcium score of like 330. But I earned that calcium score because of my youth and my eating, 3 to 6 eggs a day, ring bologna sandwiches, steaks, hams. That's how a bowl of ice cream every night before I went to bed with M&Ms and chocolate syrup sprinkled on top. That was my diet.
That sounds pretty good.
I had a massive stroke at 18. You don't think I knew I had a bad artery score? Do you think I was going to have heart surgery? I changed my diet. I knew what caused my problems. I knew. And here I am, 77 years old. So what is that, 40 years? And on a good day, you'd see me out windsurfing, going 34 miles an hour on an 1.5-inch fiberglass board with no chest pain. Not bad, huh? Because I stopped the cause of the problem. So yeah, the calcium's not going to go away, by the way. So don't even bother retesting it. You've got those calcium deposits in your scar tissue, in your aortas. They're going to be there. I would guess mine are still there too. You just don't want them to get worse. Calcium deposits are part of the end stage of inflammation. Let me just go into a little detail there. If you constantly irritate your shoulder, say, you've got tendons and burses in the shoulder. If the doctor takes an x-ray of your shoulder, you'll see calcification of the tendons and burses from chronic inflammation, from this chronic pain. Okay, if you go to get tuberculosis, the way we used to diagnose tuberculosis, and I still do, is by finding miliary, which means thousands, of calcifications in the lungs. So you flip up this chest x-ray and the whole thing lights up with calcifications from the TB, from the chronic inflammation, from this bacteria. If you get a mammogram, the most common thing you're told is that you have calcifications of your milk ducts and that this may be cancer. Well, they have the same underlying cause, which is the rich Western diet, but they don't turn into cancers. All right. So this calcification is all healed. It's scar tissue. It's from chronic inflammation of your milk ducts from the food. So, inflammation, injury, you get injury, like smoking cigarettes, you injure. The inflammation, which is the mucus and the cough and the wheezing, that's the inflammation. It follows injury, okay? I know you hear inflammation as the cause of problems. No, it's the result of damage. That's what it is. And then as time goes on, the healing processes end up with scar tissue and calcium. It's just the end stage of chronic inflammation. You got a score of 69 because of the way you used to eat. Stop doing that. Statins, by the way, are not going to reverse it. That's been studied.
So somebody's asking, what if it isn't an estrogen-driven cancer, like triple negative breast cancer?
That doesn't mean it's not estrogen.
They're saying it's not estrogen-based. They're saying it's not estrogen-based.
Well, that is estrogen-based.
Okay.
Okay, what they're talking about is they're talking about estrogen positive and estrogen negatives. Estrogen positive is more common in postmenopausal women. When the studies were done, they're called the Trialist studies. They were done in Britain in the 1970s, where they gave hormone replacement therapy to hormone positive and hormone negative women. Both of them benefited, both with estrogen positive and estrogen negative, and progesterone. They both benefited from the same therapy. I can only imagine, and it's an imagination I have, that what they did is they sat down and they said, well, look, we can just treat the positives, the postmenopausal women, with these tamoxifen drugs, and we can treat the other ones, the estrogen negative ones. We'll give them to the chemotherapists. Got to share the business. That's the only thing I can imagine that they figured out is you've got to share the business because they both respond to estrogen deprivation. So, the idea that your tumors are positive or negative does not in any way reflect whether or not your tumor responds to estrogen. Well, I didn't say that quite right. No, it doesn't really much. It doesn't make much of a difference. They both respond to these anti-estrogen drugs.
Yeah. Well, this was amazing. Thank you, Dr. McDougall.
The whole hour was amazing.
All 3 hours.
Oh, okay. Well, I always have fun talking to your group, Chef AJ, and they're very responsive. They're some of our best followings, and I just want to make sure people know. And I know you don't hesitate telling them, but Mary and I and Heather get together with you every Sunday night at 5 o'clock Pacific time on our YouTube channel. Just look up McDougall channel.
It's a good
and we'll
one.
be with you an hour. And what we do is we spend the hour answering questions. I give a little lecture in the beginning, but then we spend half an hour, 45 minutes answering your questions, just like we did this time. And then I have the opportunity to go on Chef AJ's show once a month on a Monday. And we run programs too. The next program we run is in July, and Heather tells me that one's almost full. So if you're going to get into that program, you better do it now, because by July, it'll be over full. And then the next one won't be until probably September.
Yeah.
So
Jill just asked a question about osteoporosis after I said goodbye to you, but you already did a talk on that on my channel. You did a real nice talk about that.
Yeah, probably. What you need to prevent osteoporosis, because your bones, ma'am, were designed to last you a lifetime. They weren't supposed to fall apart when you were 50. Does that make sense? Your bones should last you for a lifetime. And if they're not, you've got to think what you're doing wrong. Well, the things that make bones strong are sunshine. You need the right amount, not too much, not too little. Safe exercise. You don't want to go out and do things that'll break bones, like get hit by a car when you're bicycling. Safe exercise, like walking or in some safe environment. And the food. You want to eat a low acid diet, because what happens in the initial phase of osteoporosis is all the dietary acids you eat, which are your animal foods, the acid has to be neutralized, and the bones dissolve to neutralize the acid, which is the beginnings of osteoporosis. And yeah, you're right. We've done lectures on that, and I have a whole section in the women's book, which is not for free this month. Only the medicine book is free right now at our website.
All right. Well, Dr. McDougall, thank you so much.
All right, AJ, it was always a pleasure. And thank you again for the shirt. Isn't that pretty?
I love it. If I had known you were going to wear yours, I have a similar one. I would have
How
worn.
about that? How about that, huh?
That is
Pretty
such,
nice, huh?
I just think it's so. Have you ever worn it out anywhere and got comments?
Well, no. I've only worn it in the house.
Okay. Maybe you'll wear it out next time.
Well, I could. Sure. It's summertime, the short
Yeah.
sleeves. So,
Yeah. Get your vitamin D and get some nice comments when you're out and about.
well, that's what Mary and I are going to do right now. We're going to go for a walk. We usually get in a mile a day, sit in the sun for half an hour a day or so, and come back and eat McDougall meals 2, 3, 4 times a day. Not much.
What a nice life.
Well, in some ways it is, AJ, but I have to tell you, I love to work. And, the happiest times of my life was when I'm doing things like this with you, when I get a chance to talk to people and answer their questions and feel like I'm doing some good. Or if I'm preparing, like this morning, I spent a couple hours improving the lecture from last night so I can give it to you guys this morning.
Yeah.
I love doing that. I love building slide presentations and writing books and doing videos and stuff. You want to see me miserable? You give me nothing to do, and I'm miserable. So,
Yeah.
anyway.
Well, I'll keep you busy, Dr. McDougall.
Well, you're kind of that way yourself. I mean, good grief, what have you've been now going like 500 days without a break?
Yeah, I know. And it's sad to say, but on June 30th, I'm going to take a break and only do a couple of live shows a week, because my publisher, who has at one time been your publisher, needs me to hit the road and promote this book. So yeah, I can tell you, you were show number 2049, and I haven't had a break since March 19th, 2020. I was going for 5 years, but I made it 4. So
yeah. I hope you're actually going on a book tour, huh?
well, I mean, not like world tour, but Bob has set up dates and many, many podcasts. So I can't do a daily live show and do this, at least until the book comes out, because in order to be a New York Times bestseller, the pre-sales are what really matters. So he's going to have me really busy all of July and all of August.
I hope so.
Yep. And a little bit of September too. But have you ever heard of the Stanford Inn?
I actually know the people at the Stanford Inn.
Right. Well, that's one of the places I'm going, and we're going to do it on Ann Wheat's 90th birthday.
All right. Well, they're nice folks. You can get a great vegan meal there.
I know. I wish you and Mary could come. Oh my God, that would be I know you don't go anywhere. I get it.
Yeah. Well, we do. We go a few places.
Well, I'm amazed. I'm so happy you went to the Plantrician conference last year to get your award. I think that's how we get you to go to something. We give you an award.
Yeah, that'd be okay. Yeah, I was very pleased to get that award too. It was
all right.
Plantrician with a luminary award.
Yep.
And then I also got one from the American College of Lifestyle Medicine in 2019. And I initially was a bit reserved about this, but it makes me feel good. We're real happy that people saw the work Mary and I have done.
Yeah, that was great. It was a great talk.
Yeah, I haven't given that talk. Maybe I should give that talk on your show sometime.
Well, please do, because not everybody sees the plantrician talk.
Nobody's seen that talk. Why don't we plan on, if you can remind me, plan on doing that next time, the plantrician talk. It's a really, really good talk. I probably spent 6 months getting it ready. So, and I've only shown it once. No, I didn't. I showed it to a group of medical doctors. And I walked away from that audience and I thought, boy, did you make a mistake, John. They did not relate to anything you said. So I never got invited back.
Oh, well. Yeah. And I remember when you were going to go to the obesity conference and they kicked you out after they told you to speak. I remember that one.
Well, that was kind of a mistake on their part, and I probably could have handled it better too. But I think I got more publicity by letting them fire me.
Yeah.
They're going to fire me because I was going to tell them that, the people in the low carb diets they were personally unhealthy looking. They were overweight. And I wanted to point that out during the lectures. We had a bunch of fat people recommending these low carb diets, and they wouldn't let me go. So I said, okay, heck with you. But I'm not going to sit there and argue the data with you. You can manipulate the data anytime you want. I said, but let's look at real life low carbers. And I showed them pictures of Barry Sears, Lauren Cordain, Robert Atkins. And I said, look at how sick and fat all these people are. And I showed them Neil Bernard and Caldwell Esselstyn and myself, et cetera. And I said, look at these people. Look, it's your own eyes. Can you tell the difference? The low carbers are fat and sick, and they really are. Sally Fallon, good grief. That was a woman that, I'm surprised she hasn't ended up in the coffin yet. If they could find one big enough for her. Anyway, so that's a bad joke, but she's pretty porky, I'll tell you.
You mince no words, Dr. McDougall. You're fearless.
So they wouldn't let me show that. And I can understand why, but
yeah,
AJ, there are many things that you look back on, you say, I could have done that better. I'm sure you feel that way yourself.
Yeah.
So there are lots of things in my life where I start to take account of the decisions I've made. And boy, I tell you, John, you could have done a better one on that one. You really blew it there. But on the other hand, there were enough things that I did right on to get me to the point I'm at and have an opportunity to be on your show.
Yeah, well, you can pretty much, I won't censor you for the most part.
Yeah. Well, it's kind of interesting. All the time I've been on with you, as far as I know, you haven't gotten any criticism.
Not really, no. I mean, I don't think so, but at least
have I been too shy? Have I been too shy about what I have to say? Maybe I should get a little bit less reserved, huh?
No, please, no.
I should really say what I mean.
Well, I don't know if YouTube's ready for that.
Well, you know what? I would welcome some honest controversy. I don't want to hear any screaming matches. But if you found somebody who had, well, I don't want to deal with. I'm too old to deal with some of these people. I'm too old to deal with a guy that says you should eat everything from the nose to the end of the tail and everything in between. And that's what the carnivore diet says. You should eat it right from the nostrils all the way back to the tip of the tail. Feet, intestines, muscles, what?
Okay. I just got the text from the Dr. Kelly Casperson, and she did send me a randomized controlled trial. So I will send it to you for vaginal estrogen that prevents recurrent UTIs in postmenopausal women. So I think we got proof that you
probably very valid then.
Yep. So maybe you could send that to our mutual friend so she doesn't have to suffer every month.
Well, why don't you do that?
I keep doing it. And she acts like, oh, he didn't prescribe it. And I'm like, now I know you did. And she didn't take it or were willing to. So, yeah.
Yeah. Well, that kind of research is important.
Yeah. I'll send it to you anyway. I'll send it to her, but I'll send it to you too. I'll send it to both of you.
I'd like
All
to
right.
see, but you have to realize that's where we should be dealing with things. you see what's going on in the world today is there's so much division. And on one side, they claim to use science, and on the other side, they make up their own facts. You know, the same thing happened in medicine. You can either deal with the science or you can make it up. And I have to say, you know, most of my profession, in terms of dealing with their customers, they've made it up because the science doesn't support what they keep telling people. Now you decide, do you want to go based, do you want to change your life based on somebody's hunch, or do you want to do a randomized controlled trial and that kind of evidence? You decide. I mean, I have no problem knowing what I would do.
Yeah.
Anyway.
I don't know if you know this, but Crazy Farm Girl says, does the estrogen help in a vegan that has interstitial cystitis?
You know, I would look to an autoimmune problem with interstitial cystitis, you know, like dairy and stuff like that. I don't know that estrogen would help with interstitial cystitis. I have no experience with it.
Yeah. Okay. Well, thanks, Dr. McDougall. This was very
All right.
enjoyable. This is
Okie
even
dokie.
this was even longer than what was that movie? Oppenheimer.
Oh,
But
come on.
much more entertaining, in my opinion. All
It
right.
is really.
All right. Well, say hi to Mary, and we'll see you next month, Dr. McDougall. And don't forget, every
All right,
Sunday
well,
night at 5 p.m. Pacific time, you
Yep.
can see Dr. McDougall and Mary answering your questions.
Thank you. Thank you.
Thank you,
Have a good
Dr.
week.
McDougall. You too. And
Bye-bye.
thanks all of you for watching another episode of Chef AJ Live. Please come back tomorrow at 11 a.m. for Straight Talk with Dr. Doug Lyle. Take care, everyone.